You may be thinking, am I in the right place? This doesn't feel like a surgical training center. Because it's more than that. It's an education epicenter where meeting spaces hold landmark gatherings and surgical instructors can impart and inspire. This is where technology and hospitality move in unison. A full-service medical meeting resource connected to an award-winning hospital, where life-saving surgery can be studied in the OR and practiced in the lab, and life-changing technologies find their proving ground for success. Because the world of surgery is diverse and ever-changing, we give you a place and a team that can adapt to and accommodate any training, meeting, specialty lab, or equipment need, beginning to end, thinking of every detail in between. It's where one-of-a-kind resources meet five-star service to create dynamic, seamless, unforgettable events. So if you're looking for something more in your surgical training center, well, you found the right place. It's the Nicholson Center, and it's unlike anything else.
Introducing the airlift procedure for obstructive sleep apnea. Siesta Medical has developed the ideal system of implants and instruments for performing hyoid suspension. The procedure begins with a small incision under the chin. Two very small suture anchors are placed under and behind the chin. A second small incision is made directly over the hyoid bone, and the hyoid bone is located and secured. The Revolution suture passer, which simplifies passing sutures, is used to place two loops of suture around the hyoid bone. These are then attached with girth hitches and passed through to the first incision. The sutures are then threaded into the suture anchors using preloaded threaders. With the head in a neutral position, the hyoid bone is advanced and suspended to the mandible with the suture anchors. With the Encore's suture anchors, the position of the hyoid bone can be easily controlled and adjusted at a later date. The airlift procedure is completely reversible and removable.
Hello, everyone. I'm Scott Magnuson. Welcome to day 2 for the obstructive sleep apnea surgical dissection course. This year, we're having a virtual meeting. We will miss you this year, but we'll look forward to seeing you next year. I want to recognize our course directors, Claudio Vicini from Italy, Filippo Montevecchi from Italy, and Julia Crawford from Sydney, Australia. Yesterday, we had a very successful meeting. Over 275 attendees were present during the meeting yesterday. This is a recorded session, so many of them watched it afterwards, depending on their time zone, where they are in the world. it's a tremendous meeting. I'm sorry that we can't be together, but we have 943 registrations for this meeting from 68 countries. We couldn't have this meeting without the support of our sponsors. I want to thank our gold sponsor, Airlift from Sleep Source Alliance, ENT, and also our silver sponsors, Inspire, Stryker, Philips, Olympus, and Nixoa. Thank you very much for your participation and your support of this meeting. Claudio, I think maybe you have a few comments for this morning before we begin.
Yes, I would like to commend the day of yesterday. That was great. Today will be better if possible, but it's nothing compared to what will happen next year, when we will be able to touch the hands of our attendees, to shake their hands and to guide their hands in dissection. That is a core business, is the main features of our course. So all of them are will be with us on the next year. All of them are welcome. Thank you.
Thank you. Julia, do you have any comments from yesterday's meeting?
Just to say that I think it went really well. I think we're very lucky that the Nicholson Centre and all of the staff there have done some amazing efforts to produce this. So I think
I agree. The staff has done a great job. We had a little technical difficulty this morning, but they corrected it very quickly. Filippo, good morning or afternoon for you. Do you have any comments?
Good morning to everybody. The interaction with all the attendees was great. By using the chat box, we could interact with the other attendees. It was really great.
Yes, so let me say to the attendees, welcome. There is a chat box. We don't have any opportunity for live questions and answers, but there's a chat box. During the entire presentation, you are free to enter any question or comments, and the moderators will be watching for the chat box to make any answers or comments based on your recommendations. So we're going to go ahead and get going right away. We lost a few minutes. I want to introduce again Filippo Montevecchi from Forlì, Italy. He's one of our course directors, and he's going to moderate the panel for tongue base with Dr. Stacy Ishman and Richard Lewis. Filippo?
Hi, thanks, Scott. We are starting our session. The session is on tongue base. So tongue base is very difficult to manage. I want to say tongue is very difficult to manage because inside the tongue we can have two kinds of collapses: the oral tongue and tongue base. Thanks to sleep endoscopy, nowadays we can disclose these different collapses, and it's very important in order to find the best treatment for all the patients. It's important to understand the tongue behavior, because in many cases, I'm quite sure that after surgical failure, after pharyngoplasty, the oral tongue is involved in this failure. So we have to know in our patient if the tongue is involved in the collapse. There are several techniques for managing the tongue and the tongue-based collapse. Along the year, we have performed the Chabot technique, tongue suspension, coblation, transoral robotic surgery, so many techniques. Today, we have two eminent speakers, Stacy Ishman. She is a surgical director of upper airways at Cincinnati Children's Hospital, and she is the president of International Surgical Sleep Society as well. And Richard Lewis. Richard is a great surgeon, ENT and head and neck surgeon with a great experience in Perth, Australia. So they will talk about some techniques. Stacy will focus on children, and Richard will focus on adults. I think we can start with Stacy's presentation.
Thank you for the opportunity today to talk about surgical options for the tongue and hyoid and supraglottis in children. My disclosures include some research funding from the National Institutes of Health, Massachusetts Eye and Ear Institute. I'd like to spend a little bit of time talking about the differences between adult and pediatric sleep, sites of obstruction in children, and then really focus on tongue and hyoid surgeries in addition to a little bit about surgery. When we think about the differences between adult and pediatric sleep, they include age incidence. As you get older, you're more likely to get sleep apnea in adulthood, whereas the peak incidence in children is between 2 and 6 when tonsils and adenoids are at their largest. In addition, we know there's a male predominance in adults, whereas there's some debate in children, as younger studies seem to show that males and females have an equal incidence of obstructive sleep apnea, although this may look more like the adult disease as they get towards their teenage years. In addition, when we think about obesity, obese adults are more likely to have very severe obstructive sleep apnea as opposed to obese kids, who are more likely to have mild disease with resolution more easily than we see in adults. In addition, sleepiness is uncommon in children as they tend to have more behavioral or cognition issues, as opposed to adults where daytime sleepiness is a common complaint. I'll talk a little bit about sleep architecture in a minute, but including this fact that children oftentimes have persistent flow limitation versus the discrete events that are seen in adults. And this can be important because if you have a 2 or 3 minute long hypopnea is not uncommon in children, you can imagine this will significantly reduce the apnea-hypopnea index as opposed to an adult who has multiple discrete events in the same time period. In addition to this partial airway obstruction, which is more common in kids, they're also more likely to desaturate from short apneas or hypopneas. And this is because they have a lower functional residual capacity in addition to a faster respiratory rates. Interestingly, they also are more likely to have clinically negative outcomes with mild sleep apnea, and this may be related to their arousal indices, which in kids tend to include mostly subcortical arousals, and so sleep architecture is preserved and they're less sleepy. However, it may result in more episodes of movement or autonomic changes, which parents may report as restless sleep. In addition, like we see in adult women, children are more likely to have obstructive apnea during REM. Now, when we think of sites of obstruction, the tonsils are really the one that's easiest for us to address and we like to see when we walk into our office. However, about a third of children continue to have obstructive sleep apnea after adenotonsillectomy. When we think about factors that may be influencing this, the childhood adenotonsillectomy study is shown here. They looked at a group of kids who underwent watchful waiting as opposed to those who underwent tonsillectomy at about 1 month after diagnosis, and found that kids who were Black, those who are obese, and those with severe sleep apnea are more likely to have persistent disease. This is a separate study done out of Texas where they looked at tonsil size as an influencing factor and found that kids with small tonsils are more likely to have persistent disease. They also looked at some of the same factors looked at in the chat study and also found that Black race, obesity, and severe obstructive sleep apnea are factors that contribute to persistent sleep apnea. In addition to those factors, they talked about older age or teenagers and comorbidities like craniofacial issues, neurologic issues, and developmental issues. Now, we think of sites of obstruction after TNA in children. We find that the tongue base is actually the most commonly one identified in kids. This is a cohort of about 115 children who underwent drug-induced sleep endoscopy. Lingual tonsils were also significantly seen in about 30% of kids, and about 60% of kids had some level of epiglottic collapse, with 40% diagnosed with some glottic collapse. Now, if we look in evaluation of the literature, we can see in those with the stars over them, which are kids with persistent sleep apnea, that the tongue base is actually the most commonly reported across studies, with anywhere between 40 and 80% of kids noted to have tongue base collapse, and that supraglottic collapse was noted between 20 and 40% of the kids in these studies. When we think about evaluations, they include the common ones that we talk about for adults, like physical exam and drug-induced sleep endoscopy. We've also used cine MRI or dynamic airway MRI to evaluate these children. Here you can see extremely large lingual tonsils, which are well differentiated from the tongue musculature, in addition to some enlarged adenoids here. What's also interesting is you can intermittently see some epiglottic or laryngeal collapse that's happening in this region. Just like we do in drug-induced sleep endoscopy, we look at closure patterns, and so this more circumferential pattern where we see this circular pattern is more common with circumferential collapse, and then this more oblong pattern is more common in people with AP collapse. We do think that this axial view is important. And so when we look at the cine MRI here in this axial view, you can see a lot of AP collapse, which we commonly, again, see with kids who have more tongue-based collapse. When we looked at studies of cine MRI, we found that in those that reported it, about 93% of kids had some identified site of a collapse. And in this third study, what they were looking for was the likelihood of lingual tonsil hypertrophy in those with Down syndrome, which they found in about a third of the children. Now, the indications for DICE in children are still a little bit under debate, but persistent sleep apnea or those kids with small tonsils and adenoids are probably those where there's the most consensus. In addition, it's where there's a suspicion of state-dependent laryngomalacia. And in this particular assessment or systematic review, they found that in most of the studies of DICE, sites of obstruction are identified for children. Now, I point out this one because it's an assessment of DICE prior to adenotonsillectomy. It was done out of Adam Woodwin's group. What they really found is that, not surprisingly, adenoids and tonsils were large in most of the kids, but 14 to 21% had some laryngeal findings, and they had adenotonsillectomy with no evidence of obstructive sleep apnea afterwards, suggesting that perhaps this upstream tongue-based obstruction was actually resulting in some of the downstream supraglottic collapse. And in fact, if you treat the upstream obstruction, whether that's tonsils or tongue-based, you may be more likely to resolve that laryngomalacia. So I'm going to talk today about tongue-based procedures, including partial midline glossectomy, lingual tonsillectomy, and tongue suspension in kids. I'll mention quickly hyoid or genioglottal advancement, although there's and then supraglottoplasty or epiglottoplexy. Now, partial midline glossectomy is done when the tongue falls back into the airway, whether on the DICE or the cine MRI, and closes off the palate. Success seems to be about 60% in kids in the very limited trials. There's one that I'll talk about later that's combined with tongue suspension, but this one done out of Canada showed 13 children and had, again, a success rate of about 60%, where they looked at a preliminary or pre-operative AHI of about 47 events an hour and went down to about 6. Now, what they did note is that those with obesity were less likely to resolve, but again, this is a very small cohort, though very interesting in terms of being hypothesis driving. This is how I do partial midline glossectomy with the tube in the midline. I do that, and I want my trainees to keep that co-blader underneath the tube so that I don't have to worry about the palate being injured. I do like oral intubation because I think it protects the palate. I also like this technique because it allows me to see what they're doing and allows them to participate in the case. I do use a penetrating towel clip to pull the tongue forward, and I have them make a channel in the midline. And quite honestly, I like them to do it under the tube. It's a pain at the beginning, but once you get that started, it really works very, very well. And it really does protect the palate. And you're going to see in a minute that we didn't do the best job protecting the uvula there. You can see there's a teeny little ding on the bottom of it. And we're trying to make a channel in the midline that's 2 or 3 co-bladers wide and at least 2 co-bladers deep. And what I try and do is make my way back to the vallecula. You can see the epiglottis there at the top of the picture. And I try and make a new neovallecula. I know some people here cringe at the idea that I don't try and preserve the mucosa. I have a partner who does try and preserve the mucosa. She makes an incision in the midline and then sews it back together. And I am thoroughly convinced it looks exactly the same as mine afterwards, and that when we looked at the recovery between the two techniques, there was no significant difference between the two. Tongue suspension is another one that's been then assessed in kids, usually in kids without significant macroglossia or lateral wall collapse, although honestly we've been using it in kids with Down syndrome who have obviously relative macroglossia. And it works well in those whose posterior airway space decreases dramatically from sitting to supine, which is also an about for hyoids, at least in adults. In this study, what tongue suspension suture was combined with radiofrequency to the base of tongue. The mean age of these kids was 11. Success was considered an AHI less than 5 with normal oxygen and carbon dioxide levels. And again, success rates were about 60%. And interestingly, even in the Down syndrome population, they were over 50%. This particular study called it genioglottal advancement, but really it's tongue suspension that's being referred to. Now, lingual tonsillectomy is a procedure that really has been published much more in the pediatric literature than in adults. And there are radiology studies and obviously flexible endoscopy that can easily show us hypertrophy, especially in those kids who have Down syndrome and obesity. What's interesting, and we're not yet published, is we think we're actually significantly overcalling lingual tonsil hypertrophy when we use just drug-induced sleep endoscopy is when we look on those same kids with a cine MRI, it seems that they actually have very narrow layers sometimes with a large tongue base, and then in others it's really significant lingual tonsil hypertrophy. And here you can see how easily you can differentiate that lingual tonsil tissue from the tongue-based tissue in this particular. Now, in this systematic review of lingual tonsillectomy, you can see that resolution rates were again in about the 60 rates. The AHIs often were from severe to moderate obstructive sleep apnea, typically down to mild. If you look at the means, and that oxygen saturations were significantly improved afterwards. When we look at the outcomes, again, in our group of about 40 kids, what we found was that they had significantly improved AHI, obstructive AHI, and oxygen saturation nadir. And so we do think it's reasonable to look for lingual tonsil hypertrophy, and especially with kids with Down syndrome and or obesity. We looked at the complications that we see in this group. We really found they were very similar to what we see in kids who undergo adenotonsillectomy. Any bleeding between 3 to 5% in adenotonsillectomy is pretty common. What was slightly higher probably was the likelihood of having to go back to the operating room for a confirmed bleed, as it is a little harder to see and to access in the emergency room. In the emergency room than it might for traditional adenotonsillectomy. Complication-wise, we found again that these were almost exactly the same as it was for our typical adenotonsillectomy, which was that they often came back for poor oral intake, in addition to bleeding. So we found complication rates to be comparable to TNA with bleeding rates, really in the same range depending on your definition of bleeding. And in my hands, we do lingual tonsillectomy very similar to how I described the posterior midline glossectomy. So I use that tongue retraction. I do have a bite block in place. I have the patient positioned like I'm doing a sinus surgery. So I am looking straight at the face and addressing them that way. I do on the lateral edges try and make sure that I stay on the medial side instead of trying to come down on top, so that I can let that tissue fall medially and I have less chance of hitting the sidewalls and causing any kind of scarring. As you guys all know, as you get through the lingual tonsils and you start seeing the bounce of that tongue, you know that you're in the out of the lingual tonsil tissue and in the tongue musculature. And just like I talked about with the partial midline glossectomy, I do like to see a really nice neovallecula. And I do not worry about whether or not I actually get the co-blader to remove the mucosa on the backside of the epiglottis. In fact, I most preferentially do that. Hyoid suspension and myotomy, there's really no significant pediatric data. We do use it sometimes looking at the same indications we would for adults. Again, those people who have significant retroversion of the epiglottis that happens when they go from the from the sitting to the supine position, which we can sometimes check in clinic. In addition, when you think about genioglossal advancement, again, very limited pediatric data, and some of that's because you can only consider it in older kids who have well-developed mandibles and permanent teeth, because even in the best of hands, there's risk of dental injury, and this is only possible if those teeth have all come in and the kids no longer have pediatric dentition. So I'm going to talk a little bit about supraglottoplasty and epiglottopexic in children. I think we've all seen people who have laryngomalacia. Sleep state dependent laryngomalacia is those kids who look fairly normal in the clinic. They don't have this kind of closure pattern. They don't necessarily have any stridor while awake or with exertion, but in fact have what looks like a fairly typical closure pattern for laryngomalacia while they're asleep, looking with either a DICE or bronchoscopy. They oftentimes will look a little bit different than those kids with congenital laryngomalacia, as they don't always have the redundancy that we see in smaller kids, though you sometimes can see that. And when you think about sleep state dependent laryngomalacia, we also see, just like with congenital laryngomalacia, there's significant improvement in obstructive events per hour, apopnea index in small trials. And then in this meta-analysis, they found a significant improvement in almost every study. You can see here where they've shown you graphically the pre and post AHI on the bottom, with an improvement about 10 an hour overall. There's multiple ways to do supraglottoplasty. I have many partners who will actually take some of the arytenoid tissue, the cumeniforms. I have others who will only divide the AE folds. They can either be intubated or with spontaneous breathing. How I like to do it is to suspend them with a laryngoscope. I do like them to be intubated. I think it gives me a little bit more time in those kids who are smaller who have poor respiratory reserve. It also allows me to have trainees do this without worrying about spontaneous respiration, making it so that they can't finish the case. I also think that the ET tube puts tension on the AE folds and gives me better visualization. And in this particular case, I actually use a sinus true cut. We keep an adult and pediatric size on hand, and we make 1 to 2 cuts on either side. I will oftentimes also keep a microdebrider to trim any residual tissue or to take that tissue if my instrument's not sharp. But I don't use it in about cases. Usually just the true cut does the job by itself. Obviously, there's plenty of other ways to do it. Many people will consider things like laser or supraglottic scissors. And then resection of lesions may involve things like retinoidectomy, which I've done in a limited number of cases where that was really a single site of obstruction. We typically observe these folks overnight. There's some debate about whether or not you need to keep them in the ICU. I typically don't, but we do have an airway step-down unit with really well-trained nurses. Oftentimes they're discharged home on a reflux medication once tolerating oral intake, and they're usually in the hospital for anywhere from 1 to 2 days with normal PO, really the day of surgery for a lot of them. Now, epiglottalpexy is something to also consider, where you want to try and actually scar the area from the base of tongue to the epiglottis. I'll tell you, when I showed you those tongue-based procedures where I remove the mucosa from the epiglottis, oftentimes when I go back and look at those patients postoperatively, there is a scar band between those without me throwing any kind of stitch. But there are people who will do laser without sutures and just abrade both the tongue base and the epiglottis, and others who will make either an opening or, again, use an instrument to try and abrade the mucosa on the epiglottis and the tongue base, and then throw the stitch between the two. This assessment of outcomes after primary epiglottalplexy do show improvements in oxygen saturations, and this is oxygen desaturation index they used in the study, which was significantly improved. And so it's something to consider. This happens to be one version of what epiglottalplexy looks like and when you do it with suture. And this, in fact, they went through the epiglottis and sutured it to the tongue base as opposed to just taking the mucosa or staying on the lingual side. With regards to primary treatment in this particular study, they did look at OHI and saw an improvement from about 15 events an hour down to about 3. And again, the ODI significantly improved. Now, there are some other procedures, which I'm not going to talk about here, but obviously can all be really useful in kids if you have tongue-based obstruction that you don't think is amenable to treatment, or in kids who have neural impairment or obstruction at multiple levels where you may want to consider things like trach. Thanks so much for letting me talk to you today about this topic. This is my email if you have any questions, and we hope you'll join the International Surgical Sleep Society when we are able to resume meeting in person so we can talk about these issues together.
Thank you for listening to my presentation on surgery for the tongue base in obstructive sleep apnea. During this talk, I want to talk about assessing the tongue anatomy, and then we'll go on to talk about a number of techniques in tongue-based surgery for sleep apnea, including radiofrequency tongue channeling, lingual tonsillectomy, epiglottalpexy, and non-robotic tongue-based resection. The anatomy of the tongue needs to be carefully assessed and recorded as part of the overall airway anatomy in the workup of a patient for sleep apnea surgery. I want to talk about the Friedman tongue position and Moore's classification, and then touch on the lingual tonsil size and the anatomy of the epiglottis. The Friedman tongue position was originally described with 4 positions, with position 2 being more recently subdivided into 2A and 2B. In position 1, the entire tonsillar fossa can be seen. In position 2A, which is the top right panel, the lower border of the soft palate is visible, plus part or all of the uvula. In position 2B, the free lower border of the palate is just visible, but not the uvula. In position 3, the hard and soft palates can be seen, but not the lower border of the soft palate. And in position 4, only the hard palate can be seen. This is assessed after asking the patient to fully open their mouth at least 5 times and mouth breathe with the tongue relaxed. Often some coaching is required to get the tongue to relax. And the main use of this grading system is that in combination with tonsil size, it's used as a predictor of response to UP3 surgery, with the Friedman stage 1 patients having high success rates with UP3 surgery. Moore described a tongue classification which was published in 2002, and it's a description of tongue base configuration. In type A, there is a high tongue base, and the narrowing is very high up. In type B1, there's a high tongue base with airway narrowing also behind the epiglottis. In B2, there is a diffuse column of airway narrowing extending from a high tongue base all the way down to and including the retroepiglottic area. And in position C, there's isolated retroepiglottic airway narrowing. The type of tongue-based narrowing did not correlate in this paper with the severity of the sleep apnea. So it's not a predictor of sleep apnea severity, but it's useful as a way to standardize the terminology in describing the anatomy of the tongue base. But it's also useful in formulating a plan for potential surgery to the tongue base. The size of the lingual tonsil is also important to record and consider for possible surgical treatment. The Friedman grading system for lingual tonsil size is as follows. There's a grade 0, which means there's no lingual tonsillar tissue visible. Grade 1, it has scattered lymphoid tissue. Grade 2, the lymphoid tissue covers the tongue base but has limited vertical thickness. In grade 3, the lymphoid tissue covers the tongue base with significant vertical thickness of 5 to 10 millimeters. And grade 4, the lymphoid tissue is up to or over the tip of the epiglottis. Finally, the epiglottic position is important to note. In most people, the epiglottis rests against the tongue base and lingual tonsil, and it's difficult to see into the vallecula with the nasendoscope in the nose. However, in some individuals, the epiglottis sits up vertically, and in some people it leans posteriorly, and even when they're awake in the upright position is almost touching the posterior pharyngeal wall. I always note whether or not the retro-inclined epiglottis, such as the one on the right, is due to a large lingual tonsil or a big bulky tongue-based muscle, or whether or not the epiglottis just leans posteriorly of its own volition. All these things are taken into consideration when formulating a surgical plan to deal with the epiglottis. The most important consideration when performing tongue surgery is the anatomy of the lingual artery. The lingual artery has 4 parts. The first part is from its origin passing just superior to the greater cornu of the hyoid bone. It then enters the tongue in its second part, deep to the higher glossus, and in this part gives off its dorsal lingual branches. The third part is the ascending part, where the sublingual artery is given off, and then the deep lingual artery carries on in the fourth part as the deep lingual artery between the genioglossus and the higher glossus. As it goes forward, the deep lingual artery moves closer to the dorsum of the tongue, and it becomes more and more medial. The dorsal lingual branches in the posterior third of the tongue can often be encountered during tongue-based surgery and need to be cauterized. There aren't any good landmarks to indicate where the lingual artery is going to be during surgery on the tongue. However, the circumvallate papillae are very helpful in performing tongue surgery safely. There's a point called the mid-circumvallate papillae point, and that is the midpoint between the foramen cecum and the lateral aspect of the tongue along the line of the circumvallate papillae. The midpoint of that line on both sides can be marked and a line joining them made. And posterior to that line is a safe zone in the tongue where the lingual artery will never be encountered. and one can dissect as deeply in that area with complete safety. One can still dissect lateral to the mid-circumvallate papillae point. However, the further laterally the dissection goes, the closer to the lingual artery you'll get. And I've marked the lingual artery on the slide on the left for that reason. As you know, the lingual artery lies between the genioglossus and the hyoglossus muscles, whereas the hypoglossal nerve is lateral to the hyoglossus muscle. So hypoglossal nerve damage is very unlikely, and one would probably need to encounter the lingual artery first before getting as far lateral as the hypoglossal nerve. Moving now on to some of the surgical techniques. The first one I want to discuss is radiofrequency tongue channeling. This was described by Professor Zhang, who was in Dalian in China at the time. It uses the coblation reflex 55 wand. There are two versions of this. One of them has saline irrigation in it. One of them doesn't. I don't think it matters too much which of them you use. It's a very straightforward procedure associated with very minimal morbidity. The wand is, the working part of the wand is about 18 millimeters in depth, and it's inserted into the tongue in a number of positions. A variable number of lesions can be created. Usually the minimum number of lesions is 9. The pedal is stepped on for 15 seconds to activate the wand as it's being inserted into the tongue. And this creates the radiofrequency lesion. The theoretical maximum volume reduction with 10 lesions is 7.8 mils, although it's probably somewhat less than that. Tongue channeling is usually never done on its own, but usually combined with other procedures such as palate surgery. This video shows a case of radiofrequency tongue channeling. This particular patient has had a modified UP3 performed for moderate sleep apnea. A suture is placed into the tongue to use as a retraction suture and provide anterior retraction on the tongue. The first lesions are performed in the midline, starting about halfway along the dorsum of the tongue and working back in 3 or 4 positions, approximately a centimetre at a time. You can perform more lesions in the midline if you wish. Each time the wand is inserted into the tongue to its working depth, I step on the pedal for 15 seconds with the nurse counting up as we get closer to 15. There's often a little bit of twitching of the tongue muscle during this procedure. That's to be expected. However, if the twitching is very pronounced in the lateral lesions, then I would remove the wand and reposition it. After making 3 or 4 midline lesions, I then make very often some paramedian lesions. These are usually made posterior to the circumvallate papillae and approximately a centimetre either side of the midline, and 1 or 2 of those each side are frequently made. Again, you can make more of them. When you put the wand in, it's important to pass it obliquely rather than directly perpendicular to the surface of the tongue. Next, we make some lateral lesions in the tongue, and the wand is inserted at the junction between the rough dorsal mucosa of the tongue and the smooth mucosa of the lateral aspect of the tongue. Starting just anterior to the palatoglossal fold, the wand is inserted at that junction of the 2 types of mucosa and past into the tongue, staying parallel to the dorsal surface of the tongue and aiming backwards at approximately a 45-degree angle. Usually I make 3 of these lesions each side, but occasionally for large tongues, 4 or even 5. This procedure is performed with a bite block in to keep the jaws open. And after the lesions are done on one side, the bite block is transferred to the other side as shown. And once again, 3 or 4 lesions are made on the other side of the tongue. Once again, the depth is assessed as the junction between the rough dorsal mucosa and the smooth lateral tongue mucosa. If you enter the tongue at that depth and stay parallel to the dorsal surface, you won't go near the lingual artery. As you can see, there's very minimal twitching of the tongue during this procedure. Occasionally there is some bleeding from some of these entry points. A bit of pressure on the bleeding points for a minute or 2 will usually stop that. I have on a couple of occasions had to put a vicryl suture into one of the holes to stop it bleeding. Significant hematomas of the tongue are theoretically possible, however, I've never seen that. The next procedure I wanted to talk about was lingual tonsillectomy and epiglottopexy. The size of the lingual tonsil, as you have all seen, is highly variable. During modified UP3 surgery, I very often remove a lingual tonsil if it's reasonably bulky, and in my experience, the coblator is the ideal tool to use for this. Bulky lingual tonsils can, of course, be used by removed by the surgical robot as well, but the coblation device and in particular the wand used for tonsillectomy is very effective. Now, if the epiglottis is vertical or posteriorly leaning, I usually try to perform an epiglottopexy at the same time. This is achieved by creating a raw surface on both sides of the vallecula. That is, irrespective of the size of the lingual tonsil, it is removed, or at least the mucosa on the tongue base on the anterior wall of the vallecula. And then dissection down into the depth of the vallecula and including the hyoepiglottic ligament, and then denuding the mucosa on the ventral surface of the epiglottis. I'll play the video now and you'll see a short video of that. By creating opposing raw surfaces and dissecting down into the floor of the vallecula a little, you create not only space for the vallecula to, for the epiglottis to move forward, but also for potential adherence of the lower part of the epiglottis to the tongue base. Again, the coblation wand is the ideal tool for this, and it's pretty good at cauterizing bleeders as you go. And this is just one example of a patient who had a posteriorly leaning epiglottis. This gentleman actually had palate surgery as well as this epiglottopexy, and preoperatively his epiglottis leaned posteriorly and in the supine position easily obstructed him. Using coblation and creating large raw surfaces here and dissecting down into the vallecula, I managed to get very good anterior movement of his epiglottis. Now on to tongue muscle resection. I'm going to, there have been many types of tongue muscle resection described over the years, and they all really achieve the same thing. I'm just going to talk about the cell technique and midline gastrectomy, and then also using coblation to resect tongue-based muscle but preserve mucosa. The cell technique was described by Lee and Kazarian, and is really an open tongue-based resection using coblation. The patient is intubated nasally in the tonsillectomy position, and the tonsillectomy gag is used. Visualization is provided by a 30-degree endoscope and a camera. You can either hand hold it or have an assistant hold it, or use an endoscope holder bolted onto the operating table. 3 1.5 centimetre deep vertical cuts are made into the posterior tongue with the coblation EVAC 70 wand. There's one cut in the midline of the tongue, and the lateral ones are about a centimetre lateral to the midline. They are all made posterior to the circumvallate papillae, and in this way they should all be safely away from the lingual artery. The cuts are extended up and then joined, with the tissue in between the cuts being removed with the coblator. Dissection goes right down to get good visualization of the base of the vallecula and the epiglottis. You can do some further thinning out of the tongue-based muscle at the time. The wound is left open to heal by secondary intention. Their results of their first 25 patients were published, and they had reasonable reduction in sleep apnea severity. However, all of these patients had a combined palate operation, which was a modified form of UP3. There have been a whole lot of different ways to do midline glossectomy, but they're all variations on the same theme. The simplest one is to just cut out an ellipse of posterior tongue tissue going as far posteriorly as possible, and dissecting down into the genioglossus muscle, providing hemostasis, and then suturing the wound together. This is a very straightforward technique to perform. The next technique I'd like to show is a mucosal preserving technique. This is a coblation-assisted mucosal sparing glossectomy. This is a patient who had moderate sleep apnea with an AHI of 23. However, she had very severe daytime tiredness and was unable to work a full day due to the tiredness. She was intolerant of CPAP and had minimal benefit from a splint. Her retrolingual airway was very narrow, so in the tonsillectomy position, a short tongue blade is used, and then an incision is made in the mucosa at about the level of the circumvallate papillae. I usually make a short midline incision and then flare it out either side, out towards the lateral border of the tongue. I use the needlepoint monopolar cautery for this. This is done. This can be done with a headlight, this part of the operation in most cases, or you can have an endoscope with a camera. Usually a 30-degree endoscope gives the best view, with an assistant or an endoscope holder holding the scope. Then the EVAC 70 wand is used to start to debulk the tongue-based muscle. Now, the depth of the dissection varies according to whereabouts you're dissecting. As stated earlier, between the mid-circumvallate papillae points, you can dissect as deeply as you like. it's very interesting doing this operation to look carefully at the muscle fibers as you're dissecting. The initial part of the dissection is all in the intrinsic muscle fibers, including the longitudinal and transversus muscles of the tongue, and you can really see the direction of them. In that more central part of the dissection, you'll see you can clearly see the fibers of the horizontal part of the genioglossus muscle, which sort of run directly back towards the surgeon. And you can dissect very deeply between those mid-circumvallate papillae points. Further laterally, one needs to be a little bit less aggressive as to the depth of the dissection. I stop from time to time and replace the mucosal flaps to see how much of a reduction I've got. You can see the genioglossus fibers there and just how deep that resection is. When I'm happy with the amount of tongue muscle resection, I thin down the flaps because there's still some muscle attached to them and get close to the mucosa, tidy things up and get hemostasis, and then suture the wound closed. This is a 5/8 needle with a 2/0 vicryl suture. The 5/8 needle makes it very easy to pass the needle, and several knots are tied and several sutures applied. And after reduction of the swelling, you can see that it really will debulk her tongue base nicely and make the epiglottis a lot easier to use. This patient had an excellent reduction in her sleep apnea severity. Her apnea hypopnea index reduced from 23 to 6, but more pleasingly, her daytime sleepiness almost completely resolved, and she was able to return to working a full day. Post-operatively, these patients should be nursed in a high dependency unit or have close nursing supervision. Even though this is a mucosal sparing form of tongue-based resection, it is still painful, and they will require some narcotic analgesia and close observation of the airway overnight for not only swelling and bleeding, but also for over-sedation with narcotics is important. Finally, I think that with the increasing sophistication of technology in hypoglossal nerve stimulation and the increasing availability of it, aggressive tongue-based muscle resections will probably become less commonly done. The hypoglossal nerve stimulators, I think, are really unparalleled in their ability to not only deal with a prolapsing or bulky tongue-based muscle, but also a prolapsing epiglottis, and the movement of the not only the tongue base but the epiglottis forward with this technology is quite remarkable at times.
Hello, can you hear me?
Yes, we can hear you.
Okay. Thank you, Richard. Thank you, Stacy. Thank you for answering in the chat box, because we have gained a lot of time answering in the chat box. I think we have just a couple of minutes. Tongue base is a difficult surgery. We have to take care to the patient. I agree with Julia and others. I prefer to remove the tube, the anesthesiological tube, immediately after surgery, and leave the patient inside the hospital for 24 hours. I don't know, Stacy and Richard, do you hospitalize the patient for one night or not after surgery?
I do.
Just one night.
I usually do one night because I take the tube out at the end of the case in almost everybody.
Okay, perfect. So,
And Philip, I always extubate the patients as well immediately after the operation and put them in a high dependency unit. I always put, after that sort of tongue-based surgery, I always put nasopharyngeal airways in overnight and take them out the next morning. They may stay a second night on the ward depending on what else they've had. For example, if they've had a UP3 or something like that, they may stay a second night before they go home. They all get dexamethasone intravenously overnight and maybe for the next day, and the usual post-operative analgesia.
okay, perfect. Do you perform nasal surgery at the same time or never during tongue-based surgery?
I generally don't. I don't know if you do, Stacey.
I typically do that at the time that I do my dice, but I will occasionally do something in the nose at the same time.
Yeah, I think it's a good idea performing nasal surgery immediately after dies, and then perform tongue-based surgery. Maybe we had a problem of connection. Okay, can you hear me?
Yes.
Yep.
Okay, perfect.
We can hear
Perfect. So, yes, perfect. So we are at the end of the presentation. Just for reminding to all the attendees, in this session we didn't talk about tours, about robot, but Nicholson Center is the home of robotic surgery, and there are several courses every year about sleep and head and neck cancer treated by robotic surgery. So thank you. I leave the line to Scott.
Filippo, thank you for the session.
Yeah, welcome.
Stacey, Richard, appreciate everything this morning. There's been some great discussion on the chat box. So for all those who are attending, one of the advantages with having this virtual webinar is that the presenters, because their presentation has been pre-recorded, the presenter is able to answer questions in real time. So if you have the opportunity to get on the chat box, ask a question, the presenters are reading the chats during the presentation. So it's been a great discussion this morning, a lot more discussion than we had yesterday. We're moving on to our next panel. The next panel is led by Dr. Alan Schwartz. He's a pulmonologist and sleep medicine specialist from Johns Hopkins. Alan is joined with Ed Weaver from Seattle and Stuart Mackay from Wollongong, from Sydney area. Ed, you must be pretty brave to get up at 4 o'clock in the morning in Seattle, and Stu, you must be quite knackered at 11 p.m. At your time. I apologize. This is one of the tough things about not having a meeting in person, but there will be no jet lag with you. So, Alan, welcome. Good to see you. I'll let you introduce your panelists, and you have 90 minutes. We look forward to your section. Thank you.
Great. Thanks so much, Scott. I assume all I do is just share my screen. Is that the idea?
Yes, you just share your screen, Alan.
Okay. Fair enough. Are you seeing it? Just to confirm?
Yes, we're reading your Gmail right now.
Great. Could you answer it as well? That's great. All right. Well, I'm joined by Stuart Mackay and with Ed Weaver. Both are challenged from a circadian point of view. So pleasure to speak with you. And both are illustrious surgeons. And my claim to fame is really the distinction that I'm the only non-surgical guy in the house. So you'll, with that caveat, you'll bear with me. Let me. This session is really focused on sleep studies, the diagnostics that go into your decision making. And so what I'd like to do is I'm gonna cover some of the basics, pepper my panelists with, since they are on the line and their voices are open to us. I'm gonna pepper my panelists with some case examples and hopefully have some dialogue back and forth. And then Ed Weaver is going to go through a case that's got some ins and outs and helps to illustrate a number of the problems and issues that might be considered pitfalls in the process. So why don't we get started? By way of conflict of interest, I've been involved with a number of different projects through the years, mostly dealing with upper airway patency, upper airway physiology and control, most recently in the area of neurostimulation, but for both central and obstructive sleep apnea, and also, as you'll see, for diagnostics. And some of the examples will call on some of the reports that I've gotten through some work with Itamar Medical, the WatchPat device. So the goals here are really to talk and lead from examples here, primarily with home testing, because for better or worse, it is here to stay. And we'll talk about two styles of home testing: the flow-based, where we've got airflow, nasal, and oronasal airflow-based testing modalities. And then I'll call the second arousal-based testing. But either way, my main issue here is that you should be able to really read the graphic displays and the reports of both and extract similar types of information. And then I'd like to illustrate some challenges that we have with sleep apnea diagnosis. And the diagnostics per se really lead to a number of different sort of very, very typical, somewhat stereotypic diagnostic dilemmas, if you will, or issues that I think are really important for sleep surgeons to be considering as they're looking at their reports and they're trying to get a handle on what the underlying nocturnal physiology is. So let's dig into home testing. Home testing really essentially was originally conceived in the early 90s as a stripped down version of the polysomnogram. Polysomnogram having full EEG, EMG, and respiratory and cardiopulmonary signals really gave us a very easy view of sleep apnea. In the olden days, 30, 40, 50 years ago, as the disorder was first coming to be described, it was really easy to see apneic episodes, as you see here in the bottom trace. A desaturation of some size was associated with a reduction or complete absence of airflow, followed by microarousals from sleep. And these basic features were evident from 6 miles away. You could even just pop an oximeter on most of your patients in those days, because subtle forms of sleep apnea were effectively not being detected. And it's from that milieu that what we found is that some initial cardiopulmonary devices with limited number of channels were promulgated in order to diagnose this disorder. And those devices really basically captured the airflow, the effort, and the desaturation. And it's from those devices that we have learned to distinguish apneic and hypopneic episodes from a limited number of channels. And I will call these devices, most of them now involved with home testing, flow-based home sleep apnea testing. And the reason for that is really straightforward. They detect the decreases in flow at night. They oftentimes have a respiratory effort channel, and if the effort is present and the flow is diminished, then it's obstructive, and if the effort is absent and the flow is diminished, then it's usually called a central event. And associated with that, you can pick up the oxygen desaturations and count up the apneas and hypopneas. But there is, importantly, no detection of arousals from sleep. And so we are missing, in a sense, one of the major sort of physiologic outcomes, acute physiologic responses to sleep apnea, simply because we're not seeing evidence of the sleep disruption generally speaking, in these devices. And because these devices don't have EEG, what we find as well is, in fact, the absence of EMG denies us the opportunity to really see the impact of the repetitive apneas on sleep architecture, on the overall sleep structure. As a result of that, we are a little bit limited because we're counting up the numbers of apneas and hypopneas, but we're dividing by the total recording time, not by the total sleep time. And since patients never sleep 100% of the night, the recording time is always greater than the total sleep time. And it's on that account that we distinguish from the AHI the respiratory event index, which is the total events divided by recording rather than total sleep time. And it's as a result of the lack of total sleep time that we see that in a study some years ago, we see that the percentage of the population diagnosed with polygraphy, with limited home testing, as having sleep apnea, that percentage of the population is considerably less than would be with standard in-lab full EEG-based polysomnography. And it's not only that we're somewhat less sensitive with flow-based technologies for diagnosing the disorder, but in fact, we're underestimating the severity of the disorder, since polysomnography discloses a greater proportion of the population with severe, moderate, or moderate sleep apnea than, say, polygraphy, these limited cardiopulmonary recordings. It's really on that basis that I would really highlight one other approach. It's captured by the WatchPat device, but there is one other device that's just come on the market called the Night Owl device. And this device really tees off your ability to measure alpha sympathetic adrenergic activity in the finger. This finger probe actually gives you an accurate index of sympathetic activation, as might occur when patients arouse themselves from sleep. And when they arouse from sleep, they vasoconstrict, and the amplitude of this signal goes down considerably. In addition, the heart rate increases, and it's that combination of a rise in heart rate and a decrease in the PAT amplitude that really allows the device to pick up the microarousals that terminate most apneic and hypopneic episodes. The device also incorporates some actigraphy for staging sleep-wake, and also has a respiratory sensor here, namely a snoring and a chest motion sensor that sticks to the upper chest. You also get a body position sensor. Now let's take a look at an example of a recording from this type of device. And as mentioned, this device is worn on the finger, the wrist, and a button on the upper chest. It does not measure and monitor airflow, but instead picks up these microarousals. And as mentioned, those microarousals occur when the PAT signal, the peripheral arterial tonometry signal, attenuates, meaning there's been sudden vasoconstriction in the vessels in the fingertip, and the pulse rises at the same time. We'll call that the reciprocal pattern because it indicates that there's been a microarousal from sleep. In essence, the finger, the sensor on the finger, gives us a dipstick directly into the brain and is sensitive to sympathetic activity. Now, it's only a matter of figuring out whether the microarousals themselves are due to some respiratory disturbance. And for that purpose, these types of devices look at either concomitant oxygen desaturations or some change in the snoring pattern or the respiratory effort that indicates that there's been a distinct disturbance in respiration. It's on that basis that these devices count up, they detect the arousals, the respiratory disturbances, they count up the sleep disorder breathing events, but they generally go one step further because they've got sleep-wake monitoring with actigraphy, and non-REM versus REM turns out to have major changes in sympathetic tone in the finger. These devices can actually calculate total sleep time, non-REM, and REM time. And so the raw event counts are divided by the various stages of sleep. And that's what really generates a relatively accurate apnea-hypopnea index, which is namely the numbers of sleep disorder breathing events divided by the total sleep time rather than the total recording time. And so you get a little bit different view of sleep disorder breathing, depending on which device you use. Nonetheless, you can make diagnostic inferences from both devices, and you should be thinking about the same considerations. I'd like to illustrate this with a couple of examples here, and we'll get our panelists involved. So don't, so please turn on your video if you're at all presentable here. And let's look at one distinct pattern, which I will call clusters of sleep disorder breathing over the course of the night. And we'll illustrate that here with these clusters here in the top half of the panel, where we see in the oximetry trace for the entire night, we see 3 or 4 distinct clusters of intermittent hypoxia or desaturations that are occurring. The pulse channel here in the red also shows us that there's a little bit more variability in the pulse when these clusters of desaturations occur. And so I'd like to turn, Stuart, I saw you briefly on your image show up on the screen here. Stuart, what do you think's going on here?
Yeah, so this patient's got some REM obstructive sleep apnea. Is that what you're asking, or?
Yeah, exactly. In other words, the clusters in this device, because the device actually identifies REM and non-REM sleep, this device actually allows you to see that there's straightforward alignment between the apneic activity here and the REM periods shown here in the red bar. And why does that happen? Well, we know that genioglossus and other pharyngeal muscles decline in their activity during REM sleep, and so the airway is oftentimes more prone to collapse during REM sleep. Now, indicators of airway collapse in this case really come in 2 parts. One is that we mentioned that we understand that there's a drop in pharyngeal muscle tone during REM sleep, suggesting that when apnea is isolated to REM sleep, it's usually obstructive and not central. But we've also got in many of these devices a snore channel shown here in the orange trace, which shows that, yeah, this is a heroic snorer. So we've got really very good evidence at a very high level without even digging into the report for a guy who's got severe REM-related sleep apnea, and it's in all likelihood obstructive, not central in nature. And that's really key because you can see the direct alignment between the apneic activity in the oximetry and the REM periods here. Polysomnogram was done concurrently with this and actually confirms the same pattern. We've got another case here of clusters of apneic activity. In this case, we've got maybe 3 or 4 clusters here. I don't know, Stuart, you want to tackle this one?
Yeah, so this one looks like, again, you're getting clustering that looks like with a change in body position. So you can see here, I can't use an arrow, I think, for your screen, but you can see the supine sleep down in the positional sensor, and you line that up with these desaturations on your watch pat. Yeah. And it looks like concomitantly on the in-lab study, the same thing's happening. So there's repetitive desaturation in supine sleep. And a couple of those line up with REM supine sleep where they're a tiny bit worse as well.
Yeah, maybe so. But the alignment, time alignment here is primarily with body position and rather than with sleep staging per se. And coincidentally, during the supine sleep, you've got what? You've got the apneic activity here, but you've got a whole lot of snoring that comes out. So what kind of sleep disorder breathing would you say this would be?
Well, that's obstructive sleep apnea. It's positional obstructive sleep apnea with apnea on their back.
And the fact that you've got so much noise production, is it apnea or hypopnea?
Well, hypopnea usually will give you sort of progressive noise production, I suppose. And apnea will usually give you noise at the end and the beginning of the event.
But we're so highly compressed that you're absolutely right. But the idea and the fact that this is continuous noise production suggests that, in fact, this is a guy who's got probably a good deal of partial airway obstruction or hypopnea rather than apnea. That's an impression or an inference that you may want to confirm by just digging into the recording for a screenshot or two. But suffice it to say, yeah, this is a guy who's got really positional apnea. Everything lines up there. And we know that positional apnea is something that can be treated with positional maneuvers. This is a meta-analysis that was published a few years ago, which really essentially in patients with this kind of pattern, you don't need to look any further. You've got positional therapy available to you, and there are a number of different modalities there. But I would also suggest that it's important to recognize positional sleep apnea, primarily because positional apnea also denotes something important about their airway patency, their airway collapsibility. And that concept really emerges from the fact that we can measure the collapsibility of the airway, a physiologic entity, which we've called the pharyngeal critical pressure, or P-crit. And it turns out that P-crit is a continuum here between very high levels that are above atmospheric in patients with obstructive apneas. Those are folks that have a completely slammed shut airway. And that contrasts with folks who have primary snoring or normal breathing with a patent airway during sleep. These are people where their critical pressure, the amount of pressure at the nose that it takes to really collapse their airway down, goes into the negative or subatmospheric range. Minus 10 or more centimeters of water applied to the nose can be demonstrated to produce obstructive sleep apnea in a normal individual. And so on that continuum, we can sort of discern different gradations of airflow obstruction during sleep, from apnea to hypopnea to a sort of intermediate category here of RERAs, respiratory related arousals, those who snore but don't arouse or desat during sleep, and finally the normal individuals. The important thing here is that the positional change is associated, from previous studies, is associated with about a 2 or 3 centimeter of water drop in the collapsing or critical pressure of the airway. And what that means is that positional changes usually never have an impact on folks that have very high levels of collapsibility. In other words, people who have obstructive apneas, not hypopneas. And so the positional response here that you see on an overnight study of any sort really denotes that you've got someone who's got partial airway obstruction or obstructive hypopneas. And that really becomes an important diagnostic inference that you can make that can guide your therapy. It not only opens the door to positional responses, but we also know that, for example, from hypoglossal nerve stimulation, we heard Richard speaking a moment ago about the Inspire or perhaps other hypoglossal devices. This is a therapeutic modality that leads to about a 3 to 5 centimeter of water drop in your critical pressure. We know that dental appliances lead to a 2 to 3 centimeter of water drop in your critical pressure. All of these modalities may be appropriate for the patient who's got a positional component or predominantly obstructive hypopneas rather than apneas from his initial recording. So these are really just designed, these cases are designed to really highlight the importance of recognizing the clustering of events, because when they occur during REM sleep, they may have one meaning, and when they occur during non-REM sleep, another meaning. I don't know whether Ed is awake or on the line, but I don't know, Ed, when you see someone with REM-related sleep apnea isolated to REM sleep, what do you think in terms of clinical outcomes from apnea that is predominantly REM and not infiltrating non-REM sleep?
Well, it depends. Sometimes that's normal, right? So-called physiologic sleep apnea. Probably not so much with full-on apneas, but if there's more subtle breathing events that are only in REM sleep, and especially if asymptomatic, may not warrant so aggressive a treatment. you know, sometimes also when the breathing pauses, especially when the more severe breathing pauses occur only during REM sleep, it actually reduces the amount of REM sleep because the person's sort of kicked out of REM sleep with the breathing pause with an arousal. So sometimes when we treat them, we actually will increase the REM sleep and sometimes even increase the AHI by increasing the amount of REM sleep, even though there's a relative improvement within REM sleep.
Yeah.
So, but yeah, it's a typical pattern where things tend to be worse in REM than non-REM just because of the physiology of what happens during REM. I don't ignore it, but I put those caveats on it.
And it turns out, you know, when you look at isolated REM apnea, it's hard to extract from epidemiologic data a mortality, an increased mortality in those with REM apnea. In earlier work relating REM apnea to daytime sleepiness with MSLT, there's been a tenuous relationship between isolated REM apnea and daytime sleepiness. And the current thinking really is that REM sleep, what's it good for? Well, it may be primarily good for preserving neurocognitive function, and it may have long-term effects on memory consolidation. It may be implicated.
The one exception might be, although it's not proven yet, is the postmenopausal female with suspicion of risk of atrial fibrillation, but I guess there's a lot more research to flow under the bridge before we can say that's the case.
Yeah, but you're absolutely right. Apnea in general is being highlighted as a risk factor for AFib or for AFib recurrence in people who have been cardioverted or cardioablated for their disorder. So absolutely. So the jury's still out on REM apnea, but it is a distinct pattern. And I really take Ed's point that, you know, you may actually be treating it. They have more REM, and then their HI overall for the night may go up, not down, even though there's been a partial improvement in their REM apnea. So I'd like to actually now proceed to really an important topic, I think, from the ENT surgery perspective, and that really has to do with how you can really, at a glance, distinguish whether your patient has purely obstructive events or whether you're dealing with some sort of underlying central or chain stroke sleep apnea pathogenesis, because it has major implications in terms of whether or not you decide to even consider surgical options that address the upper airway. And so what I'd like to do is I'd like to start out with an obvious case of someone who's got obstructive sleep apnea, namely a 53-year-old man. He's American, and his BMI is 81.7. So this is not subtle. And when you look at his home sleep apnea test, you might be asking the question, does he have sleep apnea? But I think probably more appropriate is it's a foregone conclusion that this guy's going to have apnea to some degree. The issues really here have to do with, can you recognize at a glance the severity of the apnea? And because severely obese individuals often have central and chain stroke breathing from Pickwickian syndrome, is the apnea predominantly obstructive, or is it central in etiology? And so here's a snapshot again, and I would encourage you, when you get home sleep apnea test results back and you get a report back, everyone goes for the numbers and we look for the AHI and various other oxygen desaturation index. I would encourage you to start with whatever trend graphs you're given and build your own mental impressions from the trend graphs, from the graphic display on the report. Build your own mental impressions about what's going on before you look at the tabular data in the report itself. And the reason for that is that if your mental impressions, your visual inferences from the graphs actually run counter to the tabular data on AHI and ODI and all the other statistics you get, then you should be really thinking a little bit harder about and questioning whether those statistics that you get are actually accurate. We'll illustrate that with a couple more cases here. In this case, though, Stuart, you want to give us just a real quick impression from the trend graphs here?
So it looks like this patient, this looks like from your snore meter, if it's reliable, the patient's snoring in all positions, but really the overwhelming factor is the extent and repetitive nature of the oxygen desaturation throughout the night. And probably importantly in this patient with a massive BMI is that you are seeing return to baseline. So you're not getting that sort of hollowed out non-return to baseline that you get in obesity hypoventilation syndrome. So this is really severe obstructive sleep apnea more than likely. Ideally, you just want to correlate that, given your previous question, with thoraco-abdominal efforts. So you'd want to look at some plethysmography to see what's happening there.
Yeah, yeah. So what makes you think it's obstructive? I agree with you. It's obviously a guy who's got really severe apnea, it's clear. Why obstructive? You mentioned the snoring as one clue.
Correct. The return to baseline, the baseline saturation between events, which often in mixed apnea or in obesity hypoventilation, you don't necessarily always see.
Sure, absolutely.
Yeah. There's probably going to be something in the relationship to, I mean, it seems to be worse in REM sleep in terms of the
yeah, it's worse in REM. Sure. Yeah, and so you've got these three areas here, Stuart, three areas where we've got really severe dips, and they somehow or another correlate, at least in part, with the REM periods. There's one outlying REM period that doesn't have the severe dips, but most of the REM sleep, whatever they've automatically scored as REM sleep, is associated with these severe dips. So REM sleep is when muscle tone goes down, the airway can become more collapsible, and we're seeing evidence of that potentially in this recording example as well here. What about the pulse here, the red signal here? What
so you're looking for heart rate variability as a marker of potentially of sympathetic nervous system being switched on. But it does look like there's a lot of variability with these. I mean, it's going up and down the whole trace the whole night, pretty much.
Yeah. How about the period during wakefulness? More or less variability?
Yeah, less variability. More variability the worse the events throughout the night.
Yeah. So you would infer then that this kind of heart rate variability is really being driven by the apneic activity.
Yep. And yes, an autonomic nervous system activity as a result.
And the thing is, you've already drawn conclusions, a number of really important conclusions. His baseline SAT is high, so he doesn't seem to have at least florid manifestations of Pickwickian syndrome, where oxygen saturations during sleep will decline. He's got severe apnea, and you'd put his AHI overall, you'd give me a guesstimate, over 20 an hour, Stuart, you think?
Comfortably, you would think, yes.
Comfortably.
I mean, the only time you would see it around there is where their apneas are so long.
Right. Yeah, so you'd put them over maybe 40, 60, 80, 100, any guesses?
Well over 60, I would have thought.
Okay. Disagree, Ed, or not?
Yeah, I totally agree. Hey, Alan, can I make another point about the patterns here?
Yeah.
And that is, the watch pad is nice because it gives you the REM sleep and it gives you position. Some home sleep tests give you neither. And, but you can still infer these things. And so if you see, like in the earlier example, where you see it's only occurring in these patches and it starts at 90 minutes, you have sleep, and then occurs again at 3 hours or something, that's likely REM, and you can infer that, or at least hypothesize that. And then likewise, if you see patches that maybe are a little less regular, it may be in fact positional. So the watch pad is nice because it gives you those variables, but even if you don't have them, you can start to theorize what may be going on.
You can make your inferences, and I would say that most of the flow-based devices, although they don't necessarily give you a hypnogram like this, they oftentimes incorporate a position monitor. And so if you see these patches or clusters here that are related or that are not related to position, but they're occurring every 1 or 2 hours over the course of the night, yeah, it's probably REM-related sleep apnea. On the other hand, if you've got a position monitor, and the Night One device from Respironics has got it, and I forget whether Apnea Link's got it from ResMed, but the position, if these patches correlate with the positional changes, then you've got a positional component to your apnea. You're absolutely right. And in this case, we've really developed sort of three inferences. One is severe apnea. Two is it may well be obstructed because it seems to get worse in most of the REM periods here. And three, we're probably not dealing with a major case of obesity, hypoventilation, or Pickwickian syndrome in this guy. So this is probably predominantly obstructive. And if you wanted to confirm it, you could go into the recording and just get a snapshot of that recording. This is a 10-minute screenshot, which just shows, 15, 20 desaturations. That comes to an AHI overall of about 90 an hour. That's not a surprise, but what you can discern, even in the absence of airflow, is you see that these desaturations are preceded by a period of respiratory silence in your snore signal here. The respiratory silence leads to a gradual desaturation as oxygen is reabsorbed from the lungs. At the onset of the apnea, there's still oxygen in the lungs. And so as the apnea ensues, the desaturation on the downslope tends to be rather gradual. But when this guy has got the arousal, and in this case, it's a watch pad, it's a reciprocal pattern, an attenuation of the pad amplitude, and a surge of autonomic activity that drives your pulse rate up concomitantly. What we see here is large snores, and in the effort signal, you can see large resuscitative breaths. And so it's at apnea termination that the airway in obstructive apnea opens up suddenly, and it's that abrupt resumption of breathing here at apnea termination right here that leads to a very, very steep incline in oxygen saturation compared to the gradual decline at the onset of the apnea. And so even without an airflow signal, we've got abundant evidence that this guy has severe, predominantly obstructive sleep apnea with periods of respiratory silence, resuscitative snorts, and asymmetry in his oxygen desaturation profile, all of which really go in favor of diagnosing obstructive and not central sleep apnea. On top of that, Stuart points out correctly that the baseline O2 sat on the overnight screenshot shows that he maintains his oxygen saturations in the mid-90s, suggesting that he doesn't have a real major component of nocturnal hypoventilation or obesity hypoventilation syndrome. Obesity hypoventilation or Pickwickian syndrome oftentimes has a central or chain-Stokes component to their apneas. Well, I'd like to compare or contrast that as we look at this guy that we've already discussed here with severe obstructive sleep apnea to a little bit different pattern here in this individual. And in this individual, we see that he too has not such severe desaturations, but you can see that there are abundant desaturations for most of the night. Stuart, want to take a stab at this one?
Yeah, I mean, this guy has patches there where you're just about to point that the saturation doesn't return to baseline. It sort of hollows out there. And you can see that's happening to a degree in REM sleep.
Right.
And so you're more likely to consider alternative diagnosis to obstructive events in this one. So.
Yeah, so absolutely. And so he's got obvious intermittent hypoxia here during what is called non-REM sleep. But when he pops into REM sleep, the oxygen saturation falls a bit, but the desaturations go away. So what else do you see on this on these graphs?
Well, he's got certainly less snore, so a lot less noise.
And what do you make out of the noise that you see here?
Well, it's potential that in some of these REM episodes of not returning to baseline, there's completely no effort whatsoever. There's no, it's just completely radio silence here.
So you're highlighting that it may be a central, not obstructive problem.
Correct. Yep.
How about the
It's
noise?
quite possible
You commented about the snoring itself. I'll stop you for a sec. You see a burst of snoring noise here. Is that snoring or what?
It might be recovery there, or making a recovery noise. Otherwise, it could be a loud pet cat or dog walking in the room. No, I'm just being facetious.
Yeah. But the guy's moving around in bed. You can see the
Correct.
black signal shows that he's probably roused and he's moving in bed.
Movement. Yeah.
And here as well, and here. And so most of the noise that's being produced it could be the pets, but it also is probably the fact that the guy is just moving around in bed and rustling the sheets rather than actually producing snoring activity. So it looks like this guy's got, how much apnea would you say in non-REM there?
Well, he's probably got a little bit in non-REM, but it's because he does. What is this? Is this nadir here? Is that 80 or 90 or what's the
90%?
Yeah. Okay. So he doesn't desaturate exactly. He doesn't desaturate through the floor on any of them. So.
But the frequency of the desats, would you say it's mild, moderate, or severe?
Yeah, I think there's a lot of them, but they're just not going through the floor. So he could well have mixed apnea as well, potentially. But he's most likely to have a central or even an obesity hyperventilation syndrome.
Okay. So on the central front, why do you think he might have central?
Well, we're just not got a lot of. I'd love to see some flow.
And you know, and Stuart, you can ask for a rescue line. You've got your colleague Ed here on the line. It's only 4 o'clock in the morning for him, so I'm sure his
I'm pretty chipper right now.
Yeah, finely tuned.
Yeah, I'll add a couple of comments. Yeah, the noise is actually, you can see down on the bottom part of the tray, they're associated with awakenings on the
sure
on the hypnogram part.
Yeah.
You know, the heart rate, or sorry, the desaturation variability goes down during REM, so there's less fluctuation there, and that's suspicious, as opposed to the obstructive apnea case on the left. The excursion is greater, it goes lower, but the intermittent change is to a greater extent. There's more variability. So that's another variable in all this. In other words, a lower line that's flat is not going to be repetitive, obstructive events. And that's, in this case, we're only seeing that during REM.
Yes.
You know, REM's going to be associated with obstructive apnea, but not central apnea. And so,
the fact that
suspicious, but he may very well be having some obstructive apnea in the intervening time. The thing is, the snoring is so minimal, and it doesn't seem like they're full apneas, that it raises suspicion that may not be the case also.
Yeah, so you've got enough evidence here that you're at least suspecting that there may be a central component to his apnea. And classically, chain stroke breathing actually gets better in REM. In other words, the periodic breathing patterns tend to get a lot better in REM than in non-REM. And so you might see an AHI in non-REM sleep that Stuart said was maybe in the severe range, over 30 or so an hour, but in REM sleep, you might see only an AHI that's in the very mild range, or maybe even normal, who knows. So you've built your inferences, you built your impressions just from the graphs themselves. That's one important point. You've also really essentially raised the flag on the possibility of there being central or chain stroke breathing patterns simply because of non-REM versus REM susceptibility, or the evidence that in REM sleep the apnea might get better. But interestingly enough, there's one other clue that might go hand in hand with the idea of central or chain stroke breathing, and that's really the heart rate signal. What do you guys think of that? And feel free to contrast it to the heart rate, which, Stuart, we said in this case, the variability in the heart rate on the obstructive case was being driven by the apneic activity.
And worse in sleep. This patient also has some variability in wakefulness, which might suggest some sort of dysrhythmia that might go with their central syndrome, or they might, might
And
have.
the fact is the variability also is the same when he's not having that much apnea in REM sleep.
Correct.
So,
Yep.
so you're absolutely right. So this variability in the heart rate, it's a broad band of heart rate variability that's fluctuating over a 20 or 30 point range. This variability is not being driven by the intermittent arousals, suggesting that there's a primary dysrhythmia. And in people with Cheyne-Stokes breathing and central sleep apnea, we've already mentioned that apnea is considered a risk factor for atrial fibrillation, and vice versa. Atrial fibrillation is probably a risk factor for sleep apnea as well. In this case, in all likelihood, this guy has atrial fibrillation. So that's a reason for the susceptibility, perhaps, to Cheyne-Stokes breathing patterns. Well, if we were to look at his patterns on the overnight recording, you'll find that this is actually a guy, 75-year-old guy, normal BMI, not terribly sleepy, on a baseline PSG, had an AHI of 43 an hour, was intolerant of CPAP, used an oral appliance, and in this case, the home study, the WatchPat study, was used to examine the efficacy of the oral appliance therapy. Really good indications for home tests to get a ballpark feel for where you are with your therapy, and it's being used increasingly even in the surgical arena when we're treating sleep apnea. But we're looking here now at the REM-related events where the desaturations and the intermittent hypoxia actually gets better. But we can move to the report, the summary report, which shows that indeed the non-REM apnea hypopnea index is 46 an hour, the REM index is 7 an hour. You built the visual impressions that actually confirm these numbers. The oxygen desaturation index is roughly the same, and that central sleep apneas, at least in this case, are deemed, Cheyne-Stokes breathing is deemed to be about 2/3 of the apneic activity is central or Cheyne-Stokes in nature. So once again, you've built your visual impressions, you've confirmed, you have developed your own independent thoughts just from the graphic display. You've confirmed most of those impressions with the tabular data that's provided in the report itself. And the only thing that might remain is to maybe take a quick dip into the recording to actually confirm that these episodes look to be predominantly central and not obstructive in nature. And we can do that here really by effectively remembering the temporal evolution of central sleep apnea on a PSG or on a home-based study. This happens to be a PSG in which you can see the airflow recording, not from this patient, as the patient transitions from stage 2 to REM sleep. And you can see that the waxing and waning pattern of Cheyne-Stokes respiration during non-REM sleep gives way to a much more stable pattern of airflow and respiratory effort during REM sleep. And these waxing and waning periods of ventilation here are associated with the absence of respiratory effort in the thorax and abdomen. And so even your home device, which might measure, it might be a flow-based device, would come up with the intermittent apneas and hypopneas that you see here, that you could tag as being central and Cheyne-Stokes in nature, not obstructive, based on airflow and respiratory effort patterns. But on top of that, you've got the sort of more big picture or global view that Cheyne-Stokes breathing tends to get better as patients transition into REM sleep. And that—
Alan, can I add a comment here?
Sure, absolutely.
I want to emphasize the value of getting your impression based on the graphical display rather than just going straight to that percent central apnea metric in the table. And that is, sometimes obstructive apneas are mischaracterized as central because, especially in a polysomnography or where effort is directly measured, because the abdomen or thorax belts have slipped and are not measuring accurately. So if you look at effort alone, it's possible it looks like central apnea when in fact they're still obstructive. Whereas when you see these other corroborating bits of evidence that it's not obstructive, it builds the case. So just another example of don't go straight to the number and then draw absolute conclusions from the number without verifying with the bigger context of the overall hypnogram of all the variables.
And I totally agree. This is a two-way street where you're looking at the graphic display, you're building some impressions, check them, cross-check with the numbers. And by the same token, if you're looking at the numbers, you want to cross-check with the graphic display. And on occasion, be prepared to perhaps dip into the recording or ask your sleep colleagues to help you with that job. But it's really key, because characterizing not just the severity of the apnea, but the patterns of sleep disorder breathing are really important. We've spoken about obstructive sleep apnea already in our discussion today. We've talked about obesity, hypoventilation, and the patterns in the oximetry trace. We've spoken now about Cheyne-Stokes and central sleep apnea. And to move forward with that case, I'd also like to remind you that waxing and waning of airflow is really it really constitutes a waxing and waning or a much more sinusoidal pattern in all of the respiratory channels. Both the oximetry, where the upslope and the downslope are roughly of the same slope. The nasal airflow and the effort channels also show this sort of sinusoidal pattern of waxing and waning respiratory channels. Whereas, as we mentioned with the case of severe obstructive apnea, what we saw there is that at apnea termination, there's a sudden spike in respiratory signals. In other words, the airway opens, ventilation resumes immediately. They have been asphyxic for 20 or 30 seconds before the resumption of ventilation. And so the first breaths after the arousal are the biggest breaths. And then the breaths start sort of settling down as the patient glides off to sleep again. And so these patterns, doesn't matter what cardiopulmonary signals we're looking at, these patterns of asymmetry in the case of obstructive apnea versus symmetry in the case of central apnea become really crucial diagnostic indicators as to what kind of apnea we're dealing with. And even though the WatchPat recording doesn't necessarily give you airflow and effort in the traditional sense, you can still see that the button on the chest that measures respiratory excursions shows a waxing and waning pattern. And even the oximetry shows a much more sinusoidal or symmetrical pattern in the desats and in the resaturations from these episodes. You can also confirm that the patient had atrial fibrillation. That's no surprise. So I'd like to really just summarize that there are fingerprints and features of Cheyne-Stokes and central sleep apnea that you can glean from the report in terms of the REM, non-REM distribution and the consistency of the dips in O2 sat, but you can confirm all of those impressions by essentially looking at the symmetrical nature of any cardiorespiratory signal whatsoever. I'll pause there for a sec and see whether there's any, and I don't know, Ed or Stu, whether there have been any crucial questions that have occurred before we turn to a couple of other quick topics.
Yeah, I want to thank Tucker and others for answering the questions in the chat, because it's a little harder to answer the questions while trying to be ready for questions directed at the panelists. So thank you guys for answering those questions. I think just glancing over, I think they've been answered. And then probably needless to say, but just to tie it all up, for people who are new to sleep surgery, the reason it's important to distinguish central from obstructive apnea is because the treatment modality is very different. Obviously, we don't do surgery to treat central sleep apnea or even Cheyne-Stokes. So hence the importance for us as surgeons to be able to distinguish.
Yeah, absolutely agree. I'd like to actually visit maybe just a couple of other topics very briefly and really comment that while we've been talking about really very severe cases of central and obstructive sleep apnea, we should be really attuned to recognizing this continuum, the spectrum of upper airway obstruction from respiratory related arousals to hypopneas to apneas. And it has, as mentioned, depending on the severity of upper airway obstruction, you may have very different surgical approaches for your patients. Needless to say, if the airway is slammed shut and you have complete apneas, then you've got a pharyngeal problem. But if you've got some degree of airflow, either respiratory related arousals or hypopneas, you might be looking at the nose a little bit more critically because nasal resistance will impact on the severity of the airflow obstruction here in these disorders, whereas it won't matter whatsoever if your patient has complete apneas. And we'll see that here where we've got, various degrees of airflow obstruction here from a completely patent airway to a hypopneic and a completely slammed shut or apneic airway. This is a recording example. It is polysomnographic in nature. We've got an airflow trace and by chance an esophageal pressure, where you see that these episodes here of slightly declining airflow are associated with changes in EEG or microarousals from sleep, but we do not have complete cessation of airflow. These are hypopneas, and the hypopneas themselves can be fairly subtle. I'm not going to debate with you which AASM criteria you should use for diagnosing hypopneas, except to say that you can see that there are very, very modest desaturations of 2 to 3% in these examples, and some of the hypopneas that don't have a 3 or 4% desat might be considered respiratory related arousals or RERAs simply because they're periods of partial airflow obstruction terminated by the arousals rather than by a significant desaturation. Well, this becomes really important because these are fairly subtle. Yeah, please.
Our panelist who's been answering the questions has posed a question in the chat. I just noticed, so I thought maybe we should take a second.
Sure.
I assume it's rhetorical, but Tucker asks, what about central apnea that is driven by increased airway resistance and its effect in driving CO2 below apneic threshold? In other words, someone who has high loop gain is really sensitive to the CO2 fluctuations, has a initially obstructive or resistance pattern that then drives a central pattern. And I'll add the comment, I'm sure Tucker has seen this too, where sometimes you have quote unquote central sleep apnea and you treat, and obstructive apnea too, so mix, and you treat the obstructive and the centrals go away. And that might be a situation like that one. But can you talk a little bit about that physiology, maybe, Alan, that might drive that resistance-induced central apneas?
So I would be looking at breaths like this, and this is a whole string of and now inspiration is in the downward direction on your float signal, but every one of these breaths shows you inspiratory flow limitation. We'll see that in a little bit greater detail. But if a few of these breaths leading into this event were not flow limited, but were really just low effort breaths, non-flow limited low effort breaths, then I'd be suspecting that there's something driving the oscillations or loop gain problem that Tucker refers to. But when you've got a really just solid, sea of inspiratory flow limitation, then I think we're not dealing so much with a loop gain problem, but really an airway that is consistently partially collapsed or obstructed. And we want to look a little bit more in detail at what the characteristics of flow limitation are, because I think this is really key. And I'm going to skip over this stuff here, skip over that. I think it's going to be really, really key to look at flow limitation itself, because if there's anything that you want to really make sure that you take home with you is not to be scared off by recognizing what is a flow limited or partially obstructed pattern on your recordings. And that's illustrated here, where we're actually measuring airflow out the nose and mouth with a mask. We're looking at actually a tracheal pressure for other reasons, but you can see inspiration is a downward flow in this example. And at early inspiration, flow increases, flow into the airway increases, but suddenly is cut off or obstructed thereafter. And you know it's obstructed primarily because the effort continues to go down massively. But for all that respiratory, inspiratory effort, it's unrequited. There's no increase in flow. And so for this portion of the breath, of the inspiration, you've got huge changes in effort, but the airway is collapsing dynamically and is not showing you any increase in airflow. And that's the pattern that is likened to a waterfall, where if you look at the pressures upstream to the waterfall, the pressure upstream determines the amount of flow that's going to be going over the waterfall. But respiratory effort is the downstream pressure. And it doesn't matter how high or how not high this waterfall is. The downstream pressure doesn't make a whit of difference in terms of we'll see it in a little bit. The height of the waterfall or the amount of respiratory effort doesn't make a bit of difference in terms of how much flow you get into your airway or across the waterfall. Now, there are fingerprints and hallmark signs on the flow signal that indicate that indeed we're dealing with obstruction and not a central diathesis. And those are shown here, where we're not only seeing the flattening of the airflow, but we're seeing the snoring, the high frequency snoring artifact in the airflow, which says that, hey, yeah, this guy's got a partially obstructed airway. We've commented that the effort dissociates from the flow. And we also see that as the airway obstructs progressively, the inspirations lengthen. Initially somewhat shorter inspirations and longer expirations. But here we see, as the obstruction ensues, we see that the inspiration lengthens, leaving less room for expiration, almost a 1-to-1 ratio between expiration and inspiration, whereas here it's a 1-to-2 ratio. So that lengthening of the duty cycle is what's telling the brain is recognizing, hey, I'm not getting the air that I want despite my effort, and I've got to lengthen my inspiration in order to fill my lungs completely. There's one other sign that we'll see in just a couple minutes called negative effort dependence that indicates something about the site of collapse. Now, these patterns are really important because and they end up being important when you're troubleshooting your hypoglossal stimulation patients. Stu, you want to look at a few of these breaths here in this recording. This is an EMG at the chin. It's a pattern that is being, this guy is being stimulated for discrete bursts here and you can see the bursts of hypoglossal nerve stimulation here in the EMG recording. As mentioned, our airflow trace, inspiration is downward. Every one of these cycles is a breath, and we've got a band on the thorax and the abdomen here. Stu, what's going on here when we're stimulating?
So I think it's, I guess what you're getting to is it speaks to the question of different hypoglossal nerve stimulators, whether they're connected or synchronized to the breathing, as in when you have an airway event with, say, an Inspire device compared to bilateral nerve stimulation, as with Nyxoah, where it's set off a duty cycle of repeated sleep studies. You do repeated adjustments based on the duty cycle of airway collapse. So.
And so now as you sort of look at these breaths and point, I'll try to point what's happening when we're not stimulating, what's happening when we are stimulating.
So when we're stimulating, we're getting EMG response.
Yeah.
And you're trying to arrest the event to maintain respiration by the end of the stimulation, essentially. And so you get this peak that comes straight back up.
Yeah. Yeah, but we've got more flow, more inspiratory flow during stimulation than when we're not stimulating. And when we're not stimulating, what's the pattern? Flow limited or not flow limited?
we're just getting, when we're not stimulating, we're just getting nothing. We're just saying plateauing.
Plateauing of flow. So,
Yeah.
so very much flow limited breathing when we're not stimulating. And when we are stimulating, as we are here, flow limited or not?
No, we're getting flow again. We're getting airflow again.
So a doubling of flow, and is the breath flow limited? Is it partially obstructing or not?
Yeah, it's partially obstructing.
What makes you say?
Well, you get this little bit of oscillation there for one thing.
Okay. How about, is it flat, plateauing, or rounded?
It's rounded.
So what does that make you think? Flow limited or not flow limited?
Sorry, not so. There's less flow limitation there.
Yeah, less flow limitation, but you're hesitating because you're thinking that there's a little bit of snoring going on here as well.
Correct. There's a little bit of oscillatory movement.
Yeah.
On each of these.
Right. But the main point here is that when you're looking at sleep studies on your nerve implant patients, Inspire patients, or in Australia, perhaps the Genio patients that have been studied on protocol, you can look at these airflow traces and you can see a number of features that are really key. One is you can see the amplitude changes in the flow between a non-flow limited, between a flow limited or obstructed breath and a breath that is being stimulated. And by the way, the Inspire device tries to synchronize, but it's not perfect either. And it's the imperfections in synchrony that give you an instantaneous readout as to whether the breaths are being, whether the obstruction is being alleviated or not. And we'll see that in a moment. But we can also see not only the amplitude changes with stimulation, the increases in flow, but we can see whether the pattern of flow limitation lessens or extinguishes. And if it doesn't extinguish completely, it means that we may have a somewhat suboptimal response. So you may be considering altering the stimulation parameters somewhat in order to remove all evidence of airflow obstruction. And so just,
I mean, having said that, we're getting no real desaturation with any of that. So
absolutely. That's another really important point, is that with hypoglossal stimulation, or with, for that matter, any surgical intervention, it is often good enough during sleep to restore ventilation partially. You get much more stability in your O2 sat and in your sleep architecture, even though you're not hitting every breath precisely. And so it's really important to avoid making the perfect the enemy of the good. These signals are really helpful for two reasons. One is that they show you whether you're in therapeutic range polysomnographically, but they also give you an idea as to how and who you might be further titrating or optimizing the therapy in the case of hypoglossal stimulation. And that
Alan,
really—
can I make a devil's advocate comment?
Absolutely.
So this flow limitation that you've labeled as hypopneas illustrates the subjective nature of interpreting polysomnography.
Nice. Yeah.
And so someone might look at this, and we don't have all the data on this epic, but someone might look at it and call them hypopneas, and someone might not. And that subjective component is part of what makes hypopneas difficult to judge sometimes, because here there's no desaturation even during the hypopneas. So when there's not stimulation, there's two breaths there that are flow limited, but not enough to create a hypopnea. Now it might be creating an arousal. We don't have that, so it may be a rarer situation. But highlights the illustration there. Now with this flow, though, with this flow trace, you can kind of see the degree of improvement. So in this case, the upper airway stimulator may be doing something that we're not really even detecting on the gross numbers of a polysomnography. It's improving the flow of each breath if those hadn't been scored as hypopneas, and maybe improving that without even noticing it on an AHI. In this case, if they are scored as hypopneas, then you're improving the hypopnea index. But this is getting a little bit into the weeds of polysomnography because most surgeons aren't looking at the epic to epic tracings, but I think it's important for people to understand that for hypopneas, it's key to understand that there's a subjective element to it.
I think that's
the other issue is that I think there was something a year or two back in Journal of Clinical Sleep Medicine that suggested that with some of these patients, it's the degree of the desaturation event that actually leads to their daytime symptoms, not so much the cortical arousal. So it might be that you might still record in some of these patients a little bit of airflow limitation, cortical arousal, potentially even call it a hypopnea. But in the absence of any major desaturation with it, you might be controlling their symptoms enough without controlling every bit of their disease to reduce their daytime somnolence. But I think it was, you had an earlier graph where you questioned, is this a hypopnea or not, Alan? And I would still, I think that highlights Ed's point.
Yeah.
You look at it in one. I don't know if you can go back to that slide, because there's definitely an EEG arousal. I think that, where was it?
Here.
There's definitely EEG at the end of the event, whether it's 30% reduction in airflow. Not so sure.
Not so sure. Yeah. So that, and there's fairly little reduction in airflow, maybe a little bit of scooping out in the inspiratory flow here called negative effort dependence, but not
probably in
much.
the eye of the beholder as to whether someone that might hark back to your earlier comment about heart rate variability. I think about whether if you saw some major variability, it might change your opinion on it.
For sure. No, that's absolutely the case. And so, yeah, the word hypopnea in this other, stimulation example, these hypopneas, if you will, are not, they're not truly, defined by ASM as real hypopneas. They're just, the label there is probably a misnomer, and I should probably just say flow limited breathing here. But the time lock nature of hypoglossal stimulation really is really key. You can cut the on-off effects with a knife, and if you look over a little longer period of time, you can see that when that stimulator turns on, not in the beginning of inspiration, but in the end here, you've got a sudden spike in inspiratory flow, and in these breaths, these are really properly synchronized and stimulated, but some of these breaths, we've got some off effects, off-on effects here during the intervening breaths. And this one is terribly informative because it says, hey, we can really open the airway with the stimulator, but we've got to sync up and make sure, because if that stimulation is not on at the appropriate time, you'll sink right back to your old level of unstimulated airflow. And that becomes really key in driving the stimulation parameters. Yeah.
Yeah, and I want to point out something else that illustrates the second red box from the left. So it's 1, 2, 3, 4, fifth box there.
This one here, yeah.
One over from there.
Here.
So that one is a big effect on flow as soon as the stimulation starts, right? It's in the middle of a flow limitation, and then when it starts, it has a big improvement in flow. But if you look at the stimulation, it's actually very little stimulation at that point. And so, we sort of want to get, let's really stimulate and get the airway wide open. You don't necessarily have to do hardly anything to the airway stimulation. Probably even just the tone increase at the very beginning of that stimulation, before the EMG is really even caught up, is having an impact. So I think that has implications on people worry that, is my tongue going to be bouncing out of my mouth all the time? No, sometimes a very little bit of stimulation might be enough to alleviate the flow limitation. And it's demonstrated in that one breath, I think.
Yeah, I think it's really important. But I also think in the big picture with your hypoglossal stimulation patients, for example, Inspire, if you've got someone who's suboptimally responding, you should be really thinking about two buckets or categories of problems. One is the amplitude of the stimulation, and that's what Ed is really talking about. Do you need a lot? Do you need a little? Can you goose the gain a little bit and get this kind of action here where you're really markedly opening the airway? Suffice it to say that the airway does not respond in a linear fashion to the amount of juice that you apply to the stimulator. So that's the first possibility in a suboptimally treated Inspire patient. The second possibility has to do really with synchrony. Because in the end of the day, we're not managing the airway, but we're managing ventilation. And if we can stimulate and open the airway during inspiration, then we're going to be improving ventilation, oxygenation, and sleep architecture. And so our ability to sync up with inspiration, or in the case of other asynchronous devices, to stimulate for enough time that we're covering enough of the inspiration. This is important to maintain adequate levels of ventilation so as to prevent patients from arousing and desatting. So it's really helpful. You may not be looking at these tracings a lot, but you may be working hopefully with colleagues who are able to give you that backup support. And you can also ask intelligent questions, which is really key.
We wonder whether there might be, you know, with for Nyxoah, for example, Alan, it's a little bit harder to tell, but it might well be that some of those patients you may at a very low amplitude, you may start one nerve working at a lower threshold than the other, and the patient actually then senses it more. So the paradox there is sometimes you've got to amp up so that they have a more symmetrical response on both sides. They don't feel it as much and they don't cortically arouse. So you've got all those things that you've got to balance into the equation.
Yeah, so you're not controlling each side separately, is what I'm hearing.
Right. No, you don't. Yeah. Well, it doesn't have that built in at the moment. So.
Yeah. And in general, the asynchronous devices like, for example, the Genio with Nyxoah are stimulating at a higher duty cycle. And so the trade-off here is higher duty cycle means you're going to cover more of the time with on stimulation time, so as to overlap inspiration. But you hopefully are using a little bit less juice in the process, enough to open the airway adequately, but not necessarily stimulate the bejesus out of the airway. So important to sort of consider these two sort of buckets with stimulation patients as to where the troubleshooting needs to occur after implantation. Either amplitude issues in terms of how much juice you're applying, or timing issues, synchrony, asynchrony, or the duty cycle of stimulation. One last issue that I would encourage you guys to, we're gonna probably skip over this a little bit. You guys do a lot of DICE studies these days for obvious reasons, and suffice it to say that there's tremendous physiology in a DICE study. That if you actually look at a DICE study, but you apply some of the information that we've been talking about already, you will see flow limitation during the DICE study in your airflow tracing. And in this case, we've got catheters upstream here, right at the rim of the vela of the palate, soft palate, and we've got a downstream catheter in the epiglottis region. And we can see that downstream catheter is at the bottom of the waterfall, and patients can breathe in as much as they want. In other words, raise the height of this waterfall as much as they want. And they're still getting that plateauing of airflow, flow limitation. But when you're looking at the pressure above the site of collapse, what you're seeing here is that the pressure cuts off completely. And that's the pressure up here at the top of the waterfall that no longer sees how much effort is being expended to breathe and to get air into his lungs. And those pressures really indicate very precisely where the obstruction is occurring. Now, I know that, as ENT surgeons, you're looking visually and you're deciding, hey, I've got obstruction here and this site or that site, and, and all that's great. But I would offer you one other possibility, and that is really highlighted by the Boston group, that really looks at the inspiratory flow waveforms here and makes inferences as to what portions of the airway are actually collapsing. We've commented about the plateauing of flow during inspiration. In this case, inspiration is in the upward direction. But when we see that there's an early peak and a roll-off in that plateau, that suggests that, in fact, lateral walls are actually involved in the obstruction. And this is really published fairly extensively by the Boston group, Andrew Wellman and others with him. Epiglottic obstruction is absolutely typical in that what you see is this, what he calls pinching, a sudden change in flow that occurs when the epiglottis flips back like a toilet lid here. And you're seeing it here, this pinching off of airflow. You're seeing it here as well, where you see sudden evanescent changes in airflow as the epiglottis flips back and forth. Whereas all other types of collapse produce a more sort of gradual and steady state fingerprint on the airflow recording here, with lateral wall collapse and this negative effort dependence being perhaps one of the most important hallmark features, versus palatal collapse, which tends to be a little bit more plateaued, but shows you that during expiration on your dice, when the palate is really floppy, on expiration, positive pressures can flip that palate upward and lead to a cutoff in expiratory flow, shown here, as air exits through the mouth and not through the nose. So I'd like to highlight that you are in a position, perhaps with a little help from your sleep team, to amp up your DICE procedures, because there's just a hell of a lot of important physiology that can be captured and characterized in DICE itself. It's probably a topic for another time. I'd like to just simply summarize to say, hey, there's loads of stuff that you can extract. Even though we're relegated to a lot of home testing these days, know your device, whether it's flow-based or arousal-based. There's lots of inferences that you can make from the graphic display, and do the cross-checking with the tabular data in both of these styles of reports. And that well beyond just looking at the AHI and sort of focusing in on, hey, what's the AHI? We want to identify patterns, including clusters, obstructive versus central patterns, varying degrees of airflow obstruction, use the flow traces to troubleshoot hypoglossal stimulation, and then finally look at your DICE and consider grafting even just a flow signal on your DICE will help you identify the sites of collapse. I'm going to stop there and turn the baton over to Ed, who I think wants to share a case, or really pause for a moment if there are any questions before we do so.
Alan, I see a question just now from Ryan, who asks for, are there any fingerprints that are negative predictors for surgery on home sleep apnea testing or polysomnography that should give a surgeon pause about operating? Are any take-home little findings there? And I'm gonna load my talk up while you answer that.
While I do that, in fact, why don't I stop sharing so that you can grab the screen? Yeah, so I think we've spoken about the importance of picking up even a whiff of central etiology here. It's really important, because I think that, for me, that gives me pause. At a minimum, with someone who's got mixed apneas or hypopneas that may consist of some flow limited and non-flow limited breaths, I think what I would say is I'd like to see what happens when we open up the airway with relatively non-invasive means like a dental appliance or a CPAP mask, to see whether we have uncovered so-called CPAP emergent central sleep apnea. I think that's really key. I think people with cardiopulmonary disease in general, we've spoken a little bit about it, but I think you could go on from there to say that, listen, when you see the baseline SAT, as Stuart commented on one of our first cases, when baseline O2 SAT after apnea recovery is low during REM sleep or even during non-REM, I'm thinking about other concomitant cardiopulmonary disease. That makes me think that we are beyond just treating the upper airway and thinking that all the rest is going to melt away. And I'm thinking very seriously that a lot of these flow-based metrics need to be applied when we're troubleshooting any sort of therapy. We've talked about hypoglossal stimulation, but I really wonder whether for ENT as a field, for sleep surgery as a field, whether we should be distinguishing approaches to treat the nose from approaches to treat the pharynx globally here, because nasal problems will actually meaningfully improve. If you treat the nasal obstruction, it will meaningfully improve the RIRAs and the hypopneas, but not necessarily the apneas. And we can go into that physiology, but the physiology is absolutely, rock solid in that regard. Whereas complete apneas for me indicate really two things. Number one is nasal surgery is probably off the table unless you're doing it to make CPAP more tolerable. That's number one. And number two is you're dealing with a really heavy load on the airway that's causing it to just slam shut. And that's going to require really aggressive surgery, if it's surgery, or a rethink on other non-invasive modalities, primarily because the load itself, in the case of complete apnea, the lift, if you will, for your therapy is much greater in the case of a patient with apnea versus hypopnea.
Great, thanks, Alan. Great tips there. All right, well, so we have about 8 minutes left, and I'm going to fly through a case here. But before I do that, there's a burning question, I understand, of what happened to the beard? And the answer is it went to an anonymous recipient who will not be named. But and the sunglasses are on there to hide the identity, but you can tell the person is happy. All right, so now for the case. The point of this case, and I'm going to fly through a bunch of slides because the details of the case itself aren't important, but the point of this case is to not take the sleep test as just a black box and accept the numbers on the dictated report, but rather to dig in exactly like what Alan has been teaching us. So the sleep testing data are important for the diagnosis of the sleep apnea. It's required. And the sleep test data are important for prognosticating medical morbidity. The sleep test turns out not to be useful for helping us determine how severe the symptoms are or how much the quality of life is affected or how function is affected. And then the second take-home point is what should we aim for? What are the goals and what should we expect from sleep testing as surgical outcomes? And if we can get people to the mild range and have their symptoms controlled, that's probably sufficient and don't need to chase every last minor hypopnea after that. But also key in all this is being aware of the polysomnography confounding factors, which is a lot of what this session has talked about. So I'm going to quickly fly through the details of this case. 43-year-old male who's a physical therapist and is very active, very severe excessive daytime sleepiness for a long time despite good sleep hygiene, moderate snoring, and depression and anxiety that's severe, partly helped with medications. On exam, he's normal body weight, is hypertensive, and he has an oropharyngeal airway consistent with obstructive sleep apnea. Here's his sleep test. Apnea index is 5, apnea-hypopnea index is 18, and it's not positional. Lowest saturation is 83%, and hypoxemic burden, meaning the percent of sleep time with a saturation less than 90, was 2% of the sleep time. So moderate, mild approaching moderate obstructive sleep apnea with severe symptoms. CPAP controlled his symptoms really well, and he used it regularly, but he had dentofacial complications with maxillary retrusion and gingival loss requiring gum grafts and stuff. So it was really a bad option because of side effects, not because it didn't work. And all the other treatment options are not good options for various reasons, and so he comes for surgery. And here's his sleep endoscopy. See if this video will work. So I don't have sound on here. But you can see the velopharynx is very narrow, thick musculus usually, contributing to the narrowing there, and his hypopharynx is also quite narrow and obstructing. So multi-level obstruction. Did surgery, multi-level soft tissue surgery. The anatomy improved. So this is a baseline posterior airway space. Here's the after surgery tongue reduction, palate surgery. And the axial cuts also show improvement. And so he had great anatomic result at all levels. But here's his post-op sleep study. Apnea index went from 5 to 14. Apnea-hypopnea index went from 18 to 31, still not positional. Low saturation improved some, and hypoxemic burden improved some. The report on this will say that sleep apnea got worse. And the question is, did it really get worse? And for the sake of time, I'm just going to give my spiel on this. Well, for starters, the answer is no, it didn't get worse. For starters, the baseline was a home sleep test, and the follow-up was an in-lab diagnostic polysomnography, which is way more sensitive. So likely the baseline sleep apnea was worse, just not detected on a home sleep apnea test. And one of the ways you can tell that is the oxygen parameters, which are measured the same way on both tests, did improve. What got worse was the measures of apneas and hypopneas, which are not the same between the tests, or not as, especially in terms of the denominator, the sleep time. So why did the post-op AHI get worse? And this is something you will see from time to time. And so this is why I think it's important for us to be able to understand that. One reason the post-op AHI gets worse is because the baseline AHI is underestimated due to a home sleep apnea test. So let's say there wasn't very much sleep time, but the recording time was high. So you diluted the number of apneas and hypopneas. Same thing can happen with the split night polysomnography, where the first couple hours is diagnostic before they hit REM sleep. And the latter part, when sleep apnea tends to be worse, obstructive sleep apnea tends to be worse, was not recorded. So it's underestimating the severity of the sleep apnea. Another is if they use a different hypopnea criterion. If they use a more strict criterion at baseline compared to post-op, that can change the result. Even though the physiology is improved, it may look like it's worse. Or, as Alan had pointed out, various other factors, supine sleep and REM sleep. If they had no supine sleep or no REM sleep, when the AHI tends to be worse, then it might underestimate the disease. And then post-op, you might have persistent or worse AHI. You might have it because the sleep apnea is worse. But I wouldn't jump to that conclusion automatically, especially when you have evidence, like I showed in this case, where the anatomy was dramatically improved. In this case, it was a post-op diagnostic full night polysomnography. Another possibility is looser hypopnea criterion. So now you're counting a bunch more hypopneas that didn't even get counted the first time, or increased supine or REM sleep, where apneas and hypopneas are more likely to occur. Or you had a bunch of apneas before with a few hypopneas. Now you have a bunch of hypopneas with few apneas. It looks like it's unchanged when you look at apnea hypopnea together, but in fact, the physiology may be much improved. So things to do on this post-op sleep test: check the sleep test types, and the way the parameters are measured. And then compare stratified analysis. So compare supine versus supine sleep apnea, REM versus REM sleep apnea, rather than the whole night summary. And then look at the whole sleep test. And that's what this whole session's been about, especially look at the whole night hypnogram to get clarification. Well, it turned out in this person that poor physiologic result was probably related to residual restriction at the velopharynx. So even though on awake CT scan it was much improved, on sleep it was not much improved. Now, the lower pharynx was improved and was far more stable. I didn't show the detailed one before. It's narrow, but it's not, sorry, that's the baseline one. It's narrow, it's nearly obstructing. Here's the post-op one. You can see the some scar tissue from the tongue reduction. Now the tongue base is not collapsing, obstructing. It's still narrow here, but it's enough to maintain the airway. Well, here's the symptoms were not better either. So in this case, in summary, after the soft tissue surgery, you had improvement anatomically awake, but residual sleep apnea that's severe on physiologic measure and on functional measure, residual velopharyngeal obstruction and residual symptoms. So we then did MMA, and the MMA did not improve the anatomy any further, but it kept the airway from collapsing. So that was baseline. This was after soft tissue surgery, and then this is after the MMA. And now you can see the velopharynx is nice and open. Lower pharynx also nice and open. And here's the sleep test results. So it was home sleep apnea at baseline, in lab, and in lab at post-op after each of the surgeries. Now the apnea index, the apnea index were both much improved. Turns out the oxygen parameters aren't much further improved, but the hypoxemic burden was already 0. So the point of this is, don't just accept it when the report says the sleep apnea got worse, because unfortunately, too many times people just look at the apnea hypopnea index without paying attention to the rest of what's going on. And usually, when you scrutinize, usually you'll find evidence that the physiology is at least partly improved. It's just a matter of whether it's enough. And then that brings me to the final point of, when's it enough? And And if they're in the mild range, it turns out the risk of medical morbidity is marginal. So that's why I say, and others have said, that mild is probably an adequate goal. It doesn't assess symptoms of quiet life, so we assess those directly. And if symptoms are controlled, then you don't need to do anything further. And so in this case, despite a residual AHI of 10, I didn't recommend any further treatment because all his treatment goals were achieved and he only had mild residual sleep apnea. So just a real life example to illustrate the importance of understanding the full breadth of what's going on in a sleep test and not just take the conclusion sentence of the AHI demonstrates residual X amount of sleep apnea as the driver for what to do next. Thank you.
Alan, Ed, and Stu, thank you very much. This is an amazing panel. It was fantastic. Alan, there are a lot of questions and comments in the chat box. So if during this next presentation, if you want to go to that and look at that, it'd be very helpful, I know, to the people who are attending. And to those who are attending, I mentioned yesterday that registration is open for OSAS 2022. It will be in person, there will be hands-on dissection, but what I didn't mention is a breakout session that is led by Alan Schwartz on PSG. It's a standing room only breakout session. So for those who don't participate in dissection, Alan leads a fantastic program on PSG, how to read PSG in the detail that you went over today. I apologize, Stu and Ed, for the times. I realize as we're sitting during this panel that I did not do you any service of picking you for this panel, with Ed getting up at 3 o'clock in the morning and Stu still awake at after midnight. But thank you very much. So we'll move on to the hyoid panel. I want to thank our sponsors, especially I want to thank our gold sponsor, Airlift by Sleep Source Alliance ENT. We're going to see a little demonstration of their hyoid suspension as we get into this next panel. The next panel is led by Tucker Woodson in Wisconsin, and Claudia Vicini and Ahmed Bagat are the panelists on this panel. So, Gabe, thank you.
Introducing the Airlift procedure for obstructive sleep apnea. Siesta Medical has developed the ideal system of implants and instruments for performing hyoid suspension. The procedure begins with a small incision under the chin. 2 very small suture anchors are placed under and behind the chin. A second small incision is made directly over the hyoid bone, and the hyoid bone is located and secured. The Revolution suture passer, which simplifies passing sutures, is used to place 2 loops of suture around the hyoid bone. These are then attached with girth hitches and passed through to the first incision. The sutures are then threaded into the suture anchors using preloaded threaders. With the head in a neutral position, the hyoid bone is advanced and suspended to the mandible with the suture anchors. With the Encore's suture anchors, the position of the hyoid bone can be easily controlled and adjusted at a later date. The Airlift procedure is completely reversible and removable.
Hi, I'm Dr. Tucker Woodson from the Medical College of Wisconsin, USA, and today I'm moderating the session on hyoid surgery for sleep apnea. My co-panelists today are Dr. Claudio Vincenti from Italy and Dr. Ahmad Bagat from Egypt. We'll be talking today both about an introduction and airway evaluation. Dr. Vincenti will talk about thyrohyoid techniques. I'll talk about hyomandibular suspension, and Dr. Bagat will give his perspective on the procedures, followed by questions. We do have disclosures. The one that's significant is Siesta Medical, who makes the Encore device for hyomandibular suspension, and they've provided videos for my section of the course. The initial concept of hyoid suspension was described in the late 1980s and popularized in the 1990s by Riley and Powell. And this mid-sagittal diagram shows a lot of the concept of the procedure. I think it's important, if we're going to be doing the procedure, to understand exactly what we're trying to do. But initially the thought was that we'd pull the hyoid anteriorly, and this would improve the position of the tongue base due to the insertion of so many of the tongue base muscles onto the hyoid bone, and it would also improve epiglottic position by tightening the hyoepiglottic ligament. Even at that time, it was stated there could be concerns regarding the procedure, and that if the hyoid was over advanced, you could get a posterior rotation of the tongue base. And I do think that this can occur, although I don't know exactly how we can universally predict it. Although I think some of the patients, as we get into farther along with selection techniques, that have a longer airway, that have a longer hyoid to mandibular plane distance, probably don't do as well and are probably more likely to have this occur. The concept also of the surgery has been added to over the years, and I think this is important in that I think that it does help to tighten the lateral pharyngeal walls. And the lateral pharyngeal wall collapse is a major etiology of failure of other palatal surgeries. And I think that the hyoid advancement can actually pull and tighten the constrictor muscles and the lateral pharyngeal wall muscles. And if you do the hyoid to thyroid suspension, that lengthening effect can have some effects on tracheal tension and tightening the airway using that mechanism. And so I think there really are some potential values. This is showing the anterior posterior effect of the airway during a procedure was done under sedation. And the one challenge about this is the movement of the tongue base was limited to an area about 1 to 2 centimeters in length. That it didn't involve a long vertical segment of the airway. And I think that's a limitation of the procedure in that it does not affect a long vertical segment of the airway, but a relatively short vertical segment. And this video shows more recently the procedure done under DICE will actually do what's called a temporary hyoid suspension. We'll take make a small incision over the hyoid, dissect down, and I have a special little hooked instrument that we use to grab the hyoid and can pull it forward and do that without moving the mandible or other tissues. And one can see here, there clearly is an effect on the airway with what seems to be like a physiologic or surgically reproducible effect. And one sees some movement of the tongue forward, some of the epiglottis, but also some movement, I think, of the lateral pharyngeal walls. And so there are some mechanisms for it to work. So when I select patients myself, and Dr. Bhagat will describe his own separate indications, is I will select those patients based on a disease severity and Friedman staging system, stage 2 or 3. Patients who are Friedman stage 1 can do well with isolated UPVP or tonsillectomy, and the need for multi-level surgery is generally not required, although there clearly are exceptions. Once patients have met that criteria of being Friedman stage 2 or 3, I then assess them using a modified Moore classification and select those people class B or C, which we'll get into. I do think a short mandibular plane to hyoid distance is important because of the issues of vertical length of the airway. And then in some patients with primary epiglottic obstruction, I think this can be beneficial, although my success rate with that is more variable, and oftentimes for primary epiglottic obstruction, I would consider doing a surgery to surgically reduce the epiglottis itself. The Friedman staging system, which we're all very familiar with, the point here being that those patients that have Friedman stage 1 are likely to do well with just isolated UPVP or tonsillectomy. And it's those patients who are Friedman stage 2 and 3 that we then go on to multi-level surgeries, of which hyoid suspension is one. And really the advantage of hyoid suspension over other multi-level techniques is really it's relatively low morbidity. It's not a hugely invasive surgery compared to some of the techniques we've used in the past. So those patients on the Moore classification that I find may benefit from hyoid surgery either as part or as a significant part of their treatment would be those people that are Moore class B and C. Moore class A are predominantly those patients with enlarged lingual tonsils. Moore B have a longer tongue-based segment making up the airway, such that they have then both proximal and distal kind of tongue-based obstruction. This long segment of lower pharyngeal obstruction is present in Moore B, whereas Moore C has the tongue-based obstruction, but it's a much shorter segment. So it's predominantly then just retroepiglottic. I have a staging system on a 1 to 4 point scale that I use to measure the site of narrowing. But I would look at those people that are 3 and 4 plus narrowing, where the airway is either completely obstructed on end expiratory maneuver when supine using endoscopy, or you just see the posterior aspect of the arytenoids. And this is showing endoscopic examples of the Moore classification, Moore A being the lingual tonsils, Moore being the high tongue-based obstruction, and Moore C being the more shorter vertical segment of a tongue-based obstruction. I think for isolated hyoid procedures, Moore C is probably more beneficial. Moore B likely needs additional procedures to help stabilize the tongue base. Distribution of the different types is shown here. Moore C is a fairly common subtype, and so that means that hyoid procedures are relevant and may be significant in a number of our apnea patients we're treating surgically. Two general types of hyoid suspension can be performed. Hyomandibular, which was the initial technique described, where different materials can be used to pull the hyoid up to the mandible. It could be a suture, it can be fascia, it can be Gore-Tex. Over time, because of the challenges associated with suspension materials and the technical difficulty of attaching it to the mandible, hyothyroid suspension techniques were described, and those are kind of shown on the left there. We'll also now be describing with hyomandibular suspension some techniques where the materials are much easier to use, and some of the previous difficulties have been sorted out. There are different ways to suspend the hyoid to the thyroid cartilage. Dr. Vincenti will be describing a non-figure of 8 technique, but there are other techniques described in the literature, and it's worth to understand those. The figure of 8 technique described by Riley and Powell, the thought being that having the suture go behind the hyoid bone in a figure of 8 fashion help to lock it in a more forward position, more so than the simple loop. The loop, I think, has a significant effect on shortening the thyrohyoid distance, which improves that tracheal tug, but may not advance the hyoid bone as much as the figure of 8 suture would. And then Richard Lewis has described a transthyroid technique where both ends of the suture come out the thyroid cartilage. And when the hyoid is then tightened into this, it actually is literally pulled in front of the thyroid cartilage. That technique is associated with significantly more dysphagia, but does result in more advancement. One of the challenges over time is maintaining the position. The cartilage can change morphology over time due to the pressure of the suspension, and long-term effects of this have not been described. This is showing again the Moore Class C, our fundamental type of obstruction that we would apply this technique for. And from here, we can actually go forward with some of the actual surgical descriptions of the technique, which is what we really want to cover in this course.
Thyroidopexy is one of the most classical and most common procedure in the hyoid area for addressing the sleep apnea, especially for obstruction in retrolingual. In the video, I could like to show what is our way of surgery. First of all, it's an external approach. And the first step is to mark the landmarks on the anterior neck. Here you can see the body of the hyoid bone, the thyroid notch, and the incision that is exactly in the middle of that. It's easy to palpate the area, and when you finalize the marking, you get through the skin to the superficial muscle, to the muscle of the neck, And in this step, you see directly the dissection of the hyoid bone by a Bowie. It's easy to dissect free the body of the hyoid bone below and above. The key of this step is not to touch all the muscle from the superior and posterior aspect of the hyoid bone. Otherwise, you will miss the activity of the surgery. Then you have to approach the thyroid notch, splitting in the middle the soft tissue immediately over the thyroid notch. Working with the Bowie, the procedure is almost bloodless. Now you see very simply the thyroid notch and the wing of the thyroid cartilage. We are blunting, dissecting the side of the thyroid cartilage. We finalize this special step dividing the posterior aspect of the muscle from the hyoid bone and the thyroid notch. Now we are working from below to above, working with a big and sharply cutting needle, passing through the left ala of the thyroid cartilage, passing also around the body of the hyoid bone. The first stitch is lateral. The second stitch of the left side is medial. Retractor close to the hyoid bone is crucial in order to let the needle to get out from the superior aspect. We don't close the knots till the end of all the positioning of the suture. In all the cases, we used to pass 4 different stitches, a couple for each side. This maneuver is crucial, and you have to bite a significant amount of cartilage in order to have a firm grasping, a firm blocking of the cartilage on the hyoid bone. Now we are closing the knots, and we are securing the position using a needle driver. It's very important that you put in the right position the medial knots, not too tight, in order to avoid to broken the hyoid bone that is by itself a little bit fragile if you are too strong in the maneuver of closing the knots. When you finalize all the knots, you cut the sutures. Now, the procedure is getting to the end, and what you need now is to put a drain. Usually we use this drain with multiple holes in order to drain possible bleeding in at the area of the tongue base, which is potentially dangerous for obstruction in the post-op period. Now we are closing up the muscle around the floor of the mouth, and now we are securing the drain, and the surgery is finished.
Hyomandibular suspension. I'd like to thank Siesta Medical for the videos that are provided during this session of the course. This has been moderated by the primary surgeon. Presented by Siesta Medical.
So we'll be doing a hyoid suspension with the Encore system today. I use a single incision and just posterior to the submental crease. This is showing the revolution hyoid passer going around the hyoid bone. The hyoid has already been dissected and it's clamped with an Alice. The revolution is passed around it and the soft tissues are pushed away to expose the needle tip. The suture is then passed into the holes, and then the revolution suture passer is withdrawn, leaving the working suture in place. The sutures that will be staying in the patient, the implant sutures, are looped through the working suture and then brought back out through the other side. They're untangled and then they're looped upon themselves, after which they can be advanced to the mandible. I use 2 of these sutures and 2 screws that are fixated to the posterior surface of the mandible. I typically get between 2 to 3 centimeters of advancement depending upon the patient. The advantage of this procedure is that you can limit the amount of dissection around the hyoid bone to leave all the attendant muscles attached rather than requiring you to dissect a lot of the musculature off of the hyoid. We're drilling the holes here in the posterior surface of the mandible about 5 millimeters apart, and then placing the screws that come with the Encore system. It is a binary screw with a screw that is used to tap the bone, and then a set screw that is in the back of the bone screw that has holes in it that allow the passage of the suture. So once the bone screws are placed, the set screws are loosened, and then there's a small suture passer that is used, that is placed through the holes to retrieve the sutures and bring them out through the holes, after which they can be secured with the set screw. These are fairly easy to place. They're just inserted between the 2 tines of the loop and then brought out on both sides. The hyoid is then advanced a distance of about 2.5 centimeters, and then the set screws are secured. The wound is copiously irrigated with antibiotic impregnated saline solution, after which the wound can be closed with both Dermabond and fluoromonocryl.
This slide again, similar to the previous slides I've shown in the introduction course, shows some of the effects of the Encore suspension during general anesthesia with the surgeon pulling on the airway. It's uncertain whether or not this replicates the effects during sleep, but one can certainly see a displacement of tissues anteriorly as well as an effect on the lateral pharyngeal walls.
I'm going to speak about hyoid bone surgery, when and why to think about such surgeries, either mandibulohyoidopexy or thyrohyoidopexy. I'm Dr. Ahmed Yassin Bagat. I'm consultant of sleep surgery at Alexandria University in Egypt. And first of all, I would like to thank Dr. Scott Magnuson to be among the great sleep surgery speakers from all over the world. I'm honored also to share these presentations among my dear professors and mentors, Dr. Tucker Woodson from US and Professor Claudio Vicini from Italy. So, obstructive sleep apnea results from loss of muscle activity of the pharyngeal dilator muscles, and thus airway collapse at the hypopharynx, that means at the level of tongue base, and at the oropharynx at the level of soft palate. And the hyoid arch and its muscle attachment strongly affect the hypopharyngeal airway, mainly its patency and its resistance to collapse. Hyoid bone is an anchoring point for tongue base as well. So hyoid suspension can be done as an isolated procedure for retrolingual or retroepiglottic obstruction, or it can be an integral part of multi-level surgery in case of severe obstructive sleep apnea with CPAP failure in multi-level obstruction. We have 2 main indications to think about hyoid bone surgery or hyoid suspension. When you see such 2 signs in doing sleep endoscopy preoperatively, think about doing hyoid suspension. First is primary epiglottic collapse in patients with impending postoperative aspiration. In such cases, we have 2 main options, either to do partial epiglottectomy or epiglottopexy endoscopically, or to do hyoid suspension to advance the hyoid bone forward. And when the hyoid bone is advanced forward, it will advance the pre-epiglottic fat and thus the epiglottis forward without that risk of aspiration coming from the partial epiglotectomy or epiglottopexy. Second indication is lateral hypopharyngeal collapse of the lateral wall of the pharynx at the level of the hypopharynx, at the level of the tongue base, very low pharynx with lateral wall collapse. Here are the lateral walls of the pharynx, and these lateral walls are attached to the hyoid bone. So when you advance the hyoid bone anteriorly, it will stretch the lateral walls and give more tension to the lateral wall, avoiding lateral hypopharyngeal collapse. Here is a study was done in 1993 by Thut and colleagues, and they showed that when we increase the airway length like that by pulling the hyoid bone and suspending it, it will decrease the peak rate or the critical closing pressure of the pharynx, and this will gives more stability to the lateral walls. This is another example I have learned from Professor Claudio Vicini. When you pull this cable and you apply tension to it, it will overcome the downward force coming from the gravity on that telepheric. So the surgical rationale of hyoid bone suspension is to give tension to the lateral pharyngeal walls by means of hyoid bone relocation. We have two main types of hyoid suspension surgeries. Either to suspend the hyoid bone to the mandible upward and anterior, or to suspend the hyoid bone to the thyroid cartilage downward and again anterior. The first one is named mandibulohyoidopexy, and the second one is named thyrohyoidopexy. This interesting MRI study done in Mannheim showed that the clinical effects of hyoid suspension are more likely due to functional changes in airway collapsibility. So by giving more rigidity to the lateral wall rather than enlargement of the upper airway. So what are the good omens for higher success rate after hyoid suspension? We have three main pre-operative data that can give you a good omen for good results after surgery. The pre-operative AHI, the pre-operative BMI, and the accompanying tonsillectomy or palate surgery at the same time. So we have the rule of 30. If the AHI is less than 30 and BMI is less than 30, so it's very high success rate, up to 78%. And when we combine hyoid suspension with palate surgery and tonsillectomy, we expect higher and higher success rate, up to 90%. At the end, thank you so much. I'm honored to be among the great speakers and the great faculty of sleep surgeons. Thank you so much.
Tucker, we finished early there. Do you want to address some of these questions that we have coming across the chat box, and maybe Claudio and Ahmed can also participate?
Yeah, is my audio working here?
Yeah, we hear you good.
Okay,
yep, good. We hear you perfectly.
Yeah, I think a couple of my slides were eliminated, but Ahmed's presentation covered a number of those. Selecting the right patients, and that's one of the questions that comes up on the chat, is how do you select the two patients? I can give mine, and then Claudio and Ahmed can describe them. I will frequently do the hyoid mandible in patients when they're having combined palate surgery, because the pain is so much less. One of the advantages, I think, of the hyoid mandible is that it does have less pain. And certainly with the suture techniques that's shown, you can really pull the hyoid really quite far, really almost up to the mandible. Like I say, sometimes it could be too much in certain patients. So the patients I'll select are those patients that generally have a shorter hyoid to mandibular plane distance. If the hyoid is too low in the neck, then I would probably go more with a thyrohyoidopexy technique if it's lower in the neck than trying to pull it up to the mandible, because I want to pull the hyoid anteriorly, not really so much superiorly. And I think that's my selection of the patients. I'd be interested to know what the other panelists think as well.
For my side, I would like to stress that this technique, it's for us what I call a Jurassic technique. I don't do anymore in most of my patients. This technique was very helpful in my personal experience till some years ago, when the workhorse for palate was UP3. But moving from UP3 to ESP and then to BRP, that are techniques much more effective in splinting the lateral wall. What I felt, what I could demonstrate is that hyoid thyroidopexy, like I already demonstrated, is probably not anymore really necessary, really needed. So I reduce year by year, month by month, the number of this procedure. And what I do now, I select this technique in the same time in a multi-level setting in the same patient with nose, palate, that for me now is basically BRP. When I have a massive collapse to the lateral wall on the superior area and inferior area, is my feeling, but I have not final data for proving that the thyroidopexy may help to increase the splinting, the tension of the lateral wall, as mentioned by Tucker at the beginning of this presentation. So is my actual application for this technique that, to be very honest, I am doing no more. I completed more than 600 cases, but in the last few months, I did just 4 or 5 cases. So it's more and more less common in my practice.
Yes, I agree with Professor Claudio Vicini. After introducing lateral pharyngeal wall surgeries, hyoid bone surgery is of limited indications. Maybe for retroepiglottic collapse, not for splinting the lateral walls. And for splinting also lateral walls, we can apply MMA or maxillomandibular advancement. So it's invasive surgery. So we can. I mean, for another invasive procedure to do a very successful one, not only hyoid suspension, because we need to apply also transpalatal advancement, pharyngoplasty, or genioglossus advancement to advance the tongue base. But so hyoid suspension mainly for retroepiglottic collapse or patients with not very high tongue base obstruction.
I do find that the use of it is, is that subgroup of patients when you either do DICE or in the office have a large amount of oropharyngeal lateral wall collapse. And I find that with the expansion sphincterplasty or the barb suture techniques, that the amount of lateral wall opening is limited to a relatively short segment in the retropalatal airway segment. And so if you have a lot of lower pharyngeal lateral wall collapse, I frequently feel that they need some additional tongue-based surgery for those. And I think of many of the available tongue-based surgeries that we have, one of the real advantages of hyoid is that it is generally more or less reversible, either technique that you do, and it's less invasive than doing some of the more aggressive glossectomy techniques. So I'll save the glossectomy techniques will be probably discussed later, but they mentioned that it's the tongue base when it's large and lymphoid, then I will do more my glossectomy or TORS sort of techniques. But if I have a lot of lateral wall obstruction, then I'll tend to be concerned that my UPVP or lateral pharyngoplasty or expansion won't be enough. Now you can also use the hyoid as a salvage or secondary procedure. You don't have to do it as a primary procedure as well. And I think that's a great advantage of it. It's a not very invasive secondary procedure. In the US, it's also nice in that compared to some of the, let's say, coblation techniques that Dr. Lewis showed earlier, that many of those techniques, unfortunately, in the US aren't covered by many health insurance companies. And so some of the less invasive tongue-based procedures like that I like very much, but in the US, they're not available. So the hyoid procedure is available for that as well. So
the great advantage to thyroidopexy, in my personal experience, is a very simple technique, very easy to do, very quick, half an hour, and much more. The key point is a very stable technique compared to other technique. It was the feeling of the group of Stanford at the very beginning of their experience, but along the years, I strongly agree with their initial feeling. is cheap because you don't need special tools, but it works just for selected applications. So we have to balance the real impact that nowadays we may introduce to our practice with this technique. It's an honest technique, but in my opinion, is much less common that you have a patient suitable for thyroidopexy.
One of the questions on the chat was asking about men versus women. Does that have an effect? And certainly the thyroid cartilage in women is much less prominent. So if you're trying to get that advancement by pulling it forward in women, many times you won't get any advancement at all. You can still get possibly some of the tracheal tug effect by the shortening of the airway. But in a lot of women, that distance is also quite short. So I'm not sure that has, a big effect. And so probably the hyoid mandible is a more frequent
It's absolutely true. What I used to say is that for residents, female are better for the first cases, but you are in male with a sharp angle of the thyroid is much more difficult, much more effective, because you change it to a higher degree the position. You move forward and forward in a better way. Anyway, it's proved to be a little bit more efficient in male, but it's not statistically significant.
Yes, and I think the one of the things in the procedure actually for people to do, even with the hyoid mandible, you think with just placing a suture there, they do get quite a bit of swelling. It's normal to have some swelling around the procedure. It's not necessarily fluid, but they get a lot of submental edema. I tell people it's going to look like they've gained, 10 kilos after surgery, and that will last for about 6 weeks, even or more after surgery, and that's not uncommon. Usually, if I use an elastic chin strap and have them wear that for the first week after surgery, that reduces that to some degree. The incisions, however, are very cosmetic. The placement of the incisions. In fact, someone that's had a thyrohyopexy from 10 years ago that comes to my office, many times you can't even tell that they've had it done. It's a very cosmetic incision, so that's a plus in that sense. But yes, the thyrohyoid suspension, I don't do that very often. It's not a very common procedure. I do the thyrohyoid. I know that in the U.S. there's several pretty prominent sleep surgeons that do the hyomandibular suspension very commonly. So it's done, I think, a little bit more commonly in the U.S. than other places.
Okay, Tucker, thank you very much for this panel. Claudio, Ahmed, appreciate the participation. We're moving on to our last panel. I can't believe that this is coming to an end. It's been an excellent meeting so far. I do want to remind the attendees who are still signed on, we have over 200 people on right now, that the registration for OSAS 2022 is open. So if you'd like to register, come early, go ahead and get your name on the list, and we'll see you next year. So our last panel is on implants, and this is going to be moderated by Paul Hoff in Michigan. The panelists are Joachim Maurer in Germany and Julia Crawford, one of our course directors in Sydney. Julia sends her regrets. She is asleep. She is not going to be live. She is. Oh, Julia. Wow. I can't believe you were live. Okay, so Paul, take it away.
Thank you. Are you going to have my slides up there, or am I controlling those from my end?
You can control if you share your screen.
All right.
Is it working, Paul?
Yep, should be here.
Okay, we got it.
All right. Sorry, let me just get back to the beginning here. Okay. Well, thank you, everybody. And I really appreciate the opportunity, Scott and Claudio, Filippo, and Julia, to have the opportunity to share the experience with these wonderful panelists. Joachim Maurer from Mannheim, Germany, who has a wealth of experience in both hypoglossal nerve stimulator and, as you can see from the talks previous, in all areas of sleep, and Julia Crawford, who, as one of the directors of this meeting, I really appreciate her speaking about her experience with the Genio device, which has been being used in Australia and in Europe, but we're still in the process of bringing this to the United States. So really excited to hear more about that. I'm going to speak just briefly, just sort of introduce the topic here, and I don't have any disclosures, by the way. Just a very brief review of the pathophysiology, a case presentation to just stimulate some thought as we go into the discussions with Joachim and Julia. A sort of a food for thought on the historical review of tongue-based surgery, and then we're going to get into the talks. So we've had a lot of information about the pathophysiology of sleep, and this talk by Alan was terrific earlier today. But as you know, pharyngeal obstruction is due to disturbance in the upper airway neuromuscular control, and it's associated with the collapse of genioglottal muscle and the other pharyngeal dilators. And it's basically a two-hit process. We have blunted reflexes that are decreased tone, and we have structural deficits, which we look at as macroglossia, lymphoid hypertrophy, and then skeletal abnormalities like retrognathia and maxillary hypoplasia. And we've been through a lot of this already. Now we're going to, we've been talking pretty much about structural defects for the last 2 days. Today we're going to be working into the blunted reflexes. I always tell patients when they come into the office, you may have severe obstructive sleep apnea, but you're not snoring, you're not obstructing as you're sitting here speaking to me. So, what's the difference between awake and asleep? Well, it's pretty much the change in position and neuromuscular tone. And finally, we have some solutions to address that. Alan Schwartz again comes up here. He did a nice review article back in 2014 looking at the effect of hypoglossal nerve stimulation. And these are some pilot studies in humans from a number of different studies. There are attempts at transcutaneous stimulation. There's direct fine wire stimulation. These were not really successful because of just overstimulation of the surrounding musculature and discomfort, just not a real practical solution. But then it came down to direct hypoglossal nerve stimulation, and that's where we are now. We have 2 to 3 different stimulators that are out there. We're going to talk about 2 of them today. And 2 of the main things to think about is where the electrode is placed, and the other is the timing of stimulation. So electrode location can be placed directly on the proximal hypoglossal nerve, stimulating all branches, or it can be placed more distally. And when I say distally, that means on the branches, if you identify them correctly, the ones that protrude the tongue, the genioglossus and the geniohyoid. Then there's the timing of stimulation. We talked about this in Alan's previous presentation, but is the timing synchronous with respiration, or is this a continuous stimulation based on a duty cycle or open loop stimulation? The different companies that we're going to be discussing today, both Inspire and the Nyxoah Genio device, use different strategies. So this is just a case presentation, just a food for thought. I think one of the basic things for everybody in the audience, and people probably come from all different levels. We have 250 participants, but getting a really complete physical exam, having a data sheet that you keep together, and really gleaning all the information from the sleep study, as we saw from the previous talks on this polysomnography. But the patient's age, in this case, we have a middle-aged gentleman with a mild obesity, with a daytime somnolence, and a history of severe sleep apnea. But not just severe sleep apnea, this is dominated by hypopneas with a low central index. He does have some significant desaturations, and he's been CPAP intolerant. It's just kind of one of these guys that comes in, I can't use the machine. I haven't used it for 2 years, just not working. He had a relatively high pressure setting of 12 centimeters of water, and using a full face mask just makes this worse because it's pushing his mandible back. On physical exam, his tonsils are absent. He has no subjective nasal obstruction. Friedman tongue position is 2, and making him a Friedman stage 2. He has full dentition without any skeletal retrognathia. And on flexible laryngoscopy, he had an oblique Woodson phenotype, laryngoscopy view of 2A, Moore class C, and small lingual tonsils. I always do an awake and sedated sleep endoscopy, as you can, when I did my sleep endoscopy talk yesterday, you can see. But here you can see the awake exam. Again, tonsils are absent. He had relatively small lingual tonsils. And you can see the tongue base epiglottis, and the tongue is kind of sliding forward with Moore class C, and the epiglottis is somewhat retrodisplaced. And the sedated exam, I always use a propofol constant infusion. I usually start at 150 micrograms per kilo per minute, try to titrate upwards. And I use a BIS monitor, avoiding any drying agents or local anesthetic, trying to follow the European consensus guidelines. And you can always tell with all the extra secretions when the sedated exam's happening. And that's important because you can actually see the ripples of the mucus, helps you identify the direction of collapse and when there's actually a collapse happening. But you can see the vibration happening. A little bit of direct anterior posterior collapse, type 1 AP palate. And as we get further in, you'll see just more collapse of the tongue base and a little bit of lateral wall collapse. So the purpose of I think the sleep endoscopy here will be addressed more by the panelists in their talks. But as you can see now, there's some collapse laterally, and the tongue base is going to start to collapse into. So as we go forward with our discussion of hypoglossal nerve stimulator, the surgeon has a lot of things to think about. There's a lot of data out there. And not only is there the data on their BMI, the direction of collapse of the airway, the Woodson phenotype, all the different data. Now we're starting to think about other factors, the P-crit, the loop gain, sort of the neurophysiology of what's happening. And where does this lead us? Well, we're heading to the operating room, and we've got all these different decisions to make. Before we go to the operating room, at the time of your sleep endoscopy, all these different surgical options are available to you, depending on which country you live in and what the patient's insurance is. Those factors have to play in as well. So, we have palate surgeries, have a lot of tongue-based procedures, and we talked about many of those today. So what's next for the sleep surgeons? Too many options. So I think it's very incumbent on you as a budding sleep surgeon. I know all the people on the panel and all the experienced sleep surgeons have in their mind sort of an algorithm that guides them. And that's an important thing to do. It's not a rigid framework, but it's good to have an algorithm in mind. And this is just one that I use in general. First of all, you have to be a surgical candidate. You've had to fail conservative treatment. And these are for adults, but the kids as well. And you can pretty much break it down into mild sleep apnea, which would be more single level surgery in most cases, to moderate to severe, which is in more cases going to be multi-level surgery. Are they going to need skeletal framework surgery? Are these patients have a narrow maxilla? Do they have class 2 occlusion and retrognathia? The talk by Stanley Liu was terrific yesterday. I think we really have to keep that in mind and don't overlook the skeletal framework, because even with a powerful tool like hypoglossal nerve stimulator, you might set yourself up for failure. Single level surgery, Friedman stage 1 patients, those are great. And then the multi-level surgery, a very, very big mix of things. And then finally, we're going to get into the hypoglossal nerve stimulator. Who's a candidate for that? In 2014, we saw the STAR trial introduced to us through the New England Journal of Medicine, and this was the landmark study, and it led to the FDA approval of hypoglossal nerve stimulator. I think the panelists will probably go through the indications, but in general, these are patients who have failed treatment. The BMI now is up to 35 with an AHI between 15 and 65. Patients do need to undergo a sleep endoscopy, and there's been studies showing that concentric collapse is a poor predictor of success. And central sleep apnea needs to be identified if they have it, and central or mixed apnea cannot be over 25%. And so far we're doing these in adults, though there have been some studies done in kids with Down syndrome. It's been very successful. So with that, I did want 2 other things that I wanted to share with you. This is just an experience, and Claudia and Filippo will probably be interested in this because they really got me started in my career in sleep surgery beyond the UPPP. And in 2010, I visited with them in Forley, and the numbers you can see in the green graphics shows my numbers in TORS for tongue base. And then the hypoglossal nerve stimulator came along in 2014. I remember calling the company and saying I was interested. They thought I was a patient, and so they just deferred on me, so I didn't really get involved for another year or so. And then you can see in 2016, and just the numbers of TORS cases went down for a number of reasons. One reason because Inspire came along, but the others, I just got super selective in my criteria for doing those cases. And now I haven't done a TORS case in quite a while, and I'm just, the hypoglossal nerve stimulator is building, as of some of the hyoid suspension, coblation, other procedures. And my last slide here before I turn it over to the panel, hypoglossal nerve stimulator is much different than any other surgery you do as a sleep surgeon. It's a team approach, more so than it has been in the past. Your sleep medicine colleagues have to really buy into this, and thankfully, this is the first surgery I think that we do that they really do buy into. And so there's a good collaboration. The sleep medicine doctors will actually refer you patients. They're not afraid to send people for this kind of surgery. And if the outcomes that you get, I think that it's very warranted. So the way this is outlined is basically, patients again have to be referred in. You'll identify many on your own, but they've failed conservative treatment. Your role is pretty small. You're basically the implanting surgeon, but then you turn it over to the sleep medicine folks. They have to activate the device, they have to titrate the device, and then they have to follow up long-term. So they have a long-term commitment to these patients, just like they would with a CPAP patient. So in an ideal world, you help to identify these patients, do a great job with surgery, and then sleep medicine is going to follow these patients long-term. So it's a relationship, not unlike with cochlear implants or other implanted devices. So just something to keep in mind when you do this type of a case. Without further ado, I think that Joachim is going to go first. Is that true?
That's true, Paul.
Julia.
I need you to stop sharing your screen, please, Paul.
Okay.
Better Julia first, as she
Julia's first.
Is a bit late in the morning.
My one's actually
Julia,
recorded video.
My name is Julia Crawford. I'm an ENT and head and neck surgeon in Sydney, Australia. And today I'll be talking to you about the surgical steps that are taken during the implantation of the bilateral nerve stimulation, hypoglossal nerve stimulation device. Firstly, I'd like to say a thank you to Dr. Paul Hoff for chairing the session, but also to both the faculty and all of the staff at the Nicholson Centre who've made a transition from a dissection course in person to a virtual course possible during the COVID pandemic. So in terms of my disclosures, I do work as a consultant with Nyxoah as part of the ongoing trial in Australia. I'd like to also say a thank you to Dr. Richard Lewis, who has provided some of the operative videos, and also to Nyxoah for some of their slides. So in terms of the stimulated device, so it's exactly the same as all of the other stimulators on the market in that it aims to stimulate the hypoglossal nerve, which leads to genioglossus muscle contraction, which therefore maintains an open airway during inspiration. The difference between this system and some of the unilateral stimulation is on the market, that there's no implantable battery device and no leads. So there's essentially three components to the device. You have the implantable stimulator, which is the only thing that's operatively placed in the patient. You then have an activation clip, which sits on the outside in the submental region. This is held in place with a disposable patch, which is utilised, a new one is utilised each day. And one of the things that men need to be particularly aware of if they're going to go ahead with this device is that you cannot have a beard in the submental region. The third component to the system is the charging unit. The charging unit is essentially that the activation clip is placed on the charging unit every day. The charging unit can act almost like a reset button for the activation clip as well. So if a patient wakes up during the night and needs to get back to sleep and needs a latency period before the stimulation starts to get to sleep, then they can do this by placing the activation clip back in the charging unit. So how does the hypoglossal nerve get stimulated with respiration if there's no lead involved? So essentially what happens is that the patient's respiration cycle is determined on their baseline PSG. And so the timing of their cycle means that you would typically have a cyclical on, which is targeted for the patient's end of expiration and early inspiration to deliver the stimulus, and then an off section at the during expiration to avoid the nerve and the muscle becoming fatigued. So in terms of how this came to market, the first part was the BLAST OSA study, which was a prospective multi-centre international trial that looked at the efficacy and safety of this particular device at 6 months. This led to a CE approval being granted in March 2019. And there was minimal morbidity noted in the study, and there was improvement in overall parameters. The second component of this trial, which is now currently undergoing, is the Better Sleep trial, which is aimed at trying to remove complete concentric collapse as an exclusion criteria for the implantation of the device. The second arm of the trial, which is still ongoing, is the ELISA study in Europe, which is a post-market clinical follow-up to make sure that at 5 years the device remains safe and efficacious. So if we just look at the initial trial, which is the BLAST trial, the inclusion criteria were patients aged 21 to 75 who had to have a BMI of less than 32. They had to have failed or be intolerant of CPAP and have moderate to severe sleep apnea with an AH range of between 20 and 60. They needed to have a minimum amount of central or combined apneas, and any patients who had complete concentric collapse were excluded from the study. The primary endpoints were looking at efficacy in terms of decrease in AHI and ODI, and also the safety of the device. And it was shown to be efficacious overall, with a significant decrease in both AHI and in ODI, and an overall improvement in quality of life parameters, and there was minimal morbidity associated with the implantation of the device. So in terms of looking at the surgical steps, the basic surgical steps are that an incision is made in between the mentum and the hyoid bone. Dissection is carried out through the mylohyoid muscle, through the geniohyoid muscle to the genioglossus. The genioglossus muscle is skeletonized and the hypoglossal nerve is identified. The retrusor branch of the hypoglossal nerve to the hyoglossus is also identified and excluded from the pattern of implantation of the device. The external stimulation then occurs to make sure you're getting adequate stimulation of the hypoglossal nerve, and then the wound is closed. So just to go through this in some greater detail. So first of all, the patient is, a DICE is performed at the time of induction. The patient is intubated with an endotracheal tube and in a supine position with a shoulder roll and a head ring. The next step is implanting or is placing the NIM electrodes, which are paired electrodes. The first pair of electrodes are placed into the floor of the mouth, into the genioglossus muscle. The second set of electrodes, and it's important to try and avoid the opening of the submandibular duct in the floor of mouth. The second set of paired electrodes is placed into the lateral surface of the tongue and is aimed towards the anterior pillar of the tonsil. This is, you're trying to get into the styloglossus or the hyoglossus muscle. These are then secured with vicryl sutures and looped around in a mesentery to make sure they're not pulled out inadvertently during the case. And then the patient is prepped and draped for surgery. At induction, the patient is also given a dose of intravenous steroids and intravenous antibiotics, usually anti-staphylococcal antibiotics. The next step is the incision and dissection through the subplatysmal planes. So essentially, incision is performed through the skin with whichever device you're comfortable using, either a monopolar diathermy or a knife. The dissection is carried out through the subcutaneous tissue and platysma, and then subplatysmal flaps are raised. These skin flaps are then secured either with the use of something like Lone Stars or silk retracting sutures, or the use of a Wheatlander device just to hold the wound open. Following this, essentially you then need to dissect through the muscular layers down to the genioglossus. This is performed initially through the mylohyoid muscle. You can see here that there sometimes tends to be a bit of fat that sits just superior to the mylohyoid, and occasionally the bulk of this fat needs to be removed to make sure that there is an adequate distance between the implantable stimulated device and what will be the skin or the external stimulator. With the mylohyoid muscle, you need to divide this from the menton down to the hyoid. It's easy to identify the fibres of the mylohyoid as the fibres are horizontal. The next muscle you're going to come across is the geniohyoid, which you can see just here. Now, the geniohyoid doesn't have an obvious midline raphe, and it tends to be a really bulky and thick muscle. So it can take a little bit of dissection to get through this. And you can do this with a combination of monopolar diathermy, scissors with bipolar diathermy. It's important to get retraction from your assistant. So usually both the surgeon and the assistant will be holding the muscles, separating the muscles like you would when you're separating the muscles in the midline straps during a thyroid operation. Once you get through the once you get through the geniohyoid muscle down to the genioglossus muscle, there does tend to be evidence of a small fatty midline raphe that sits in between the genioglossus muscles, and that's when you know that you're deep enough. Sometimes the genioglossus muscle can also be slightly paler in comparison to the geniohyoid muscle. So the next step, once you've found the genioglossus, is you need to place a retractor in between the geniohyoid and the genioglossus muscle. I would typically use a Richardson retractor for this, and you'll place the surgical assistant into this plane. It's a nice areolar plane. And then you need to take the next steps towards identifying the hypoglossal nerve. So if we just look back on this video, essentially you have the hypoglossal nerve right here. This is the genioglossus here. This is the the geniohyoid, which is being retracted, and then the hyoglossus muscle is down here. At this point, the nerve has been identified. I'm just going to go back a step in the video again. So here you can see that the distal branch to the hyoglossus is being stimulated. And you can see the hyoglossus muscle here. Now, the aim of this is that you need to make sure that this hyoglossus branch is not stimulated by the device, because this will cause retrusion of the tongue rather than protrusion. Here you can see that a little pocket is being created just lateral to the genioglossus and superior to the hyoglossus muscle. And this pocket is where the wing of the electrode will be placed. So if we just look at this in a bit more detail, so here is superior, inferior, medial, and lateral. You have here the genioglossus muscle. This is the hyoglossus muscle. This is the hypoglossal nerve. And here is the nerve to hyoglossus, which is the nerve that we want to exclude from the stimulation. So initially when you get the view of the genioglossus and then the areolar tissue underneath it, you have a fascia sitting on top of the hypoglossal nerve, and there's a whole leash of vessels that tend to sit on top of this. These can bleed quite a lot, so it's important to try and get control of them. Typically, you do this with a combination of Liga clips and bipolar diathermy, making sure that you don't stimulate the hypoglossal nerve. Once you have the pocket, the hypoglossal nerve, the nerve to the hyoglossus on show, the next step is placing the implantable stimulator. So as you're doing this, you pull out the cottonoid, which has got the pocket, and then you place the electrode into that pocket. Now, the tricks here are that you need to try and not touch the electrodes on the device, as you can short circuit them. So you need to use a DeBakey forceps, trying only to touch the soft plastic part of the device. Once this has been placed, you typically then use an external stimulator to, well, first of all, you measure to make sure that the implantable device is sitting about less than 35 millimeters from the skin to the device. And then next, we'll be using the external stimulator to check and make sure that the device is working, and that you're typically getting protrusion, you're getting protrusion of the tongue with only stimulation of the genioglossus and not the hyoglossus. And you tend to do this by checking with the neurostimulator as well. Once you are satisfied that you're getting stimulation and protrusion of the tongue, the next step is parachuting the device down into it, where it's going to be secured with sutures. Now, the company's advice is that you do need to parachute the device, which means you initially need to use something to show you where you need to put the sutures in, usually a surgical clip, and then you remove the device, suture with the prescribed suture, and then parachute the device down. I think this is actually really difficult. I think that it's much easier if you've got a good enough view just to suture the device directly in, looking at it directly. The issue can be that you can damage the device with the needle. So once you have the device in place, the next step is closing the wound, so ensuring hemostasis, closing the mylohyoid and the geniohyoid with interrupted sutures, closing the platysma, and then closing the skin with monocle sutures. The next step is checking the external device again, checking the implantable device with the external stimulator, and you typically do this with the nase endoscope in place. So here you can see this is with the nase endoscope in place, and that's off and then on, and then you're checking at the base of the tongue as well, off and then on, and you can see that the tongue is lifting up off the endotracheal tube. Typically then the patients are discharged the day following on a week-long course of oral antibiotics. You ask them to avoid any heavy exercise for a period of about a week to 2 weeks. Typically they do get some bruising around the wound and can get paresthesia of the wound. So I look forward to any questions on the actual day of the presentation. Thanks very much.
Dear colleagues all over the world, I'm really glad to be part of this beautiful conference. And this year, unfortunately, it's a virtual conference, but nevertheless, I hope that you will benefit from it at the utmost possible. I have conflicts of interest with all companies working in the field of hypoglossal nerve stimulation. I want to talk with you about the system manufactured by the company Inspire. This is a system which is implanted typically on the right side, and it's approaching the distal hypoglossal nerve. And it uses a pressure sensor to give the stimulation pulses synchronized with respiration. And as such, it is having a closed loop. There are three implantable components. First, there is the implantable pulse generator, which is 46 by 51 by 8.4 millimeters in size and has a battery life of 10.9 years. It is not rechargeable. You can perform MRI at the head and at the limbs, but not at the trunk. The stimulation lead has a cuff electrode wrapped around the nerve with a shorter inner and a longer outer flap. And the pressure sensor detecting respiration is visible on the right side with the piezo facing the pleura, and at the distal anchor there are small bumps which show to the surgeon that the position of the piezo sensor is correctly positioned. The blue parts are reinforced and can be gently touched by blunt tweezers. Both leads are then connected to the IPG. The treatment course always consists of the same steps. First, the screening phase, which is involving sleep medicine and ENT, then the implantation, and after 1 month, the activation, another month or 2 months later, the titration in the sleep lab, and then the long-term follow-up. Patients can be treated with the Inspire device if they have a moderate to severe obstructive sleep apnea with an AHI between 15 to 65, if they have tried CPAP or any other positive airway pressure treatment with a failure or intolerance, and if you have excluded a complete concentric palatal collapse during DICE. The body mass index may be required to be lower than 35, or in other countries 32, but it's not a clear margin where you have to exclude the patient in every country. It is sometimes depending on the other factors, whether you can implant a patient with a BMI above 35 or not. Patients with central and mixed apneas of more than 25% of the total AHI are not suitable for this treatment. Anatomical contraindications such as huge tonsils or retrognathia have to be excluded, and other reasonable treatments, if possible and if available, of course, should be preferred in most patients. For the drug-induced sleep endoscopy, you have to document at least 2 complete respiratory cycles per level in order to see whether you have a banana-shaped unidirectional palatal movement, as called anteroposterior collapse, what you can see on this picture, or whether you have a circular shape, multidirectional palatal movement, which completely occludes the palatal area in a concentric way. Photos on the upper row show how the airway occludes at the palatal level in a concentric way from left to right. And the lower photos show an anteroposterior collapse where you have this clear banana shape closure. So the upper patient is not suitable and the lower patient is suitable for selective hypoglossal nerve stimulation. The procedure always consists of a regular stepwise approach. In the beginning, you have antibiotic prophylaxis provided, and you put nerve integrity monitoring electrodes into the tongue. You place at first the stimulation lead via an incision in the submandibular area. As a second step, you create the pocket for your implantable pulse generator, and then you can tunnel the stimulation lead to the pocket. The next step is the placing of the sensing lead via an incision at the lateral thorax area below the mamma, and you then connect it with the IPG via a subcutaneous tunnel as well. You connect everything and verify sensing and stimulation in order to check and prove that the system is working properly during surgery and before you close your incisions without putting a drain. The cuff electrode has to be placed at the distal part of the hypoglossal nerve at the so-called break point, which is the anterior margin of the hyoglossus muscle. It has to be placed there because at this spot we can divide the hypoglossal nerve into those branches which retract the tongue and those branches which advance the tongue and by that open the airway. You find this spot most easily if you look for the break point, the anterior margin of the hyoglossus muscle first, and then you dissect around the nerve in order to split the different branches. There you need hypoglossal nerve integrity monitoring in order to see the different functions of the nerve. In order to achieve good results, we have to include all extrinsic protrusors, such as the genioglossus oblique and the horizontal, all intrinsic stiffeners, such as the transverse and vertical fibers, and if possible, the C1, which innervates the geniohyoid muscle. On the other hand, we have to exclude all extrinsic retractors, such as the styloglossus and the hyoglossus muscle. This has been nicely classified by Clemens Heiser and will guide us to the correct inclusion into the cuff electrode. On the photo on the left side, you see the lateral branches left and the medial branches right, and the video now shows how after splitting and dividing those branches, we can dissect further to wrap the cuff electrode around the medial branch. Now we have placed a ribbon around the medial branch, the protrusors and stiffeners, and in the video you see how I try to slide the outer flap around the medial branch, and now it is almost placed, and the inner flap is not yet perfectly located. Now it's pushed a little bit down, and the lead is pulled out of the surgical field, and at the end you can check your nerve again with nerve integrity monitoring, the lateral branches retracting, and with the protrusion you see easily now the movement of the tongue. There's a question whether the stim lead should be over or under the digastric tendon before placing the anchor. I would say it is according to the local situation. I mostly prefer to place the lead under the digastric tendon and then put the anchor with non-resorbable braided sutures. The next step is to prepare the infraclavicular pocket for the implantable pulse generator, which should not be too big in size so that it just fits for the can. You can see here how the incision is made according to relaxed skin tension lines a little bit below the clavicle, and how the leads are already put into the can and fixed with a screw. Of course, before you can do that, you have to place the pressure sensor in the 4th or 5th intercostal space between the intercostal muscle layers. The incision is made 5 centimeters below the mamilla and 5 centimeters lateral of it, and the length is again 4 to 6 centimeters from this spot. In order to have better access, you lift the thorax before covering the patient. The intercostal pressure sensor is slid between the muscle layers, and the anchor with the orientation bumps makes us sure that we have the pressure sensor facing the pleura. The next step is to connect the leads with the IPG and to place the access lead and the IPG into the pocket. For that, we have to avoid crossing of the leads, because after years, the mechanical harm may cause a damage to the insulation, and this will then lead to an additional exchange of either the pressure sensor or the cuff electrode lead. And you can see this here on a patient on the right side on the bottom, where the insulation is completely destroyed after 8 years of use of the system. Before closing the wound, we check the pressure signal, as you can see here on the tablet. We give a test stimulation, which you will hear now. This indicates that there is a nice signal on the nerve integrity monitoring, which is also visible here. And now we check the movement of the tongue, and the anterior displacement of the tongue indicates a good function. The next day, we document the implant positions and their integrity by X-rays of the neck and the thorax. In my department, we keep the patients overnight and sometimes even a second or a third day, but this is at your discretion. Patients should avoid strenuous activities in the first 2 to 3 weeks after surgery in order to allow proper healing, and especially avoiding any seroma in the IPG pocket. Pain, swelling, and a sore throat should resolve within the first week after surgery. 1 month after surgery, the patient comes for an outpatient visit in order to check via telemetry the impedance of the system in order to check the integrity. The second check will be for the pressure signal in different body positions. And the last check is the detection of the thresholds for sensation, for functional movement, and sub-discomfort. We use a physician programmer, as you can see on the upper right side, and the patient uses his own patient programmer where he can switch on and switch off the therapy, pause it during night, for instance, while going to the toilet, and set the amplitude range according to our limits. During the check, we see a rapid right protrusion here on the left side, and in the middle we see a slow protrusion, which could be programmed with the old stimulator but not with a new one. And with a very low amplitude here, you see a mere stiffening of the tongue but no clear movement. During night in the sleep lab, another 1 to 2 months later, we then titrate the setting so that we eliminate all obstructive events and cause normal breathing and normal sleep. The so far largest study with a controlled design was the STAR pivotal trial, where 126 patients were implanted, and after 5 years, 97 could be followed, whereof 71 had voluntary polysomnographies. And you can see on the right side that the AHI remained stable over 5 years in the median of 6.2, which is a very good result. Also, quality of life on the left side came back to normal constantly during the 5 years follow-up range, as did the sleepiness measured by the Epworth Sleepiness Scale, which also went down to normal values. In daytime routine, we have published now more than 1,000 patients, and there are more than almost 2,000 patients enrolled at the moment. And you see that we can replicate the data from the control trial with the clinical post-marketing follow-up study. The morbidity is low, but of course, if you work on a nerve, you have to get informed consent for the risk of a tongue weakness and swallowing and speech problems. Mostly patients complain of stimulation-related discomfort, and in rarer cases, insomnia or tongue abrasion. So I would like to conclude that the functional treatment in cases of the normal anatomy via selective hypoglossal nerve stimulation has proven to be feasible with low risk and morbidity, but it requires a gentle surgeon using microsurgical tools. The hypoglossal nerve stimulation is effective in selected patients with good long-term adherence. And the most important for me is that we have a treatment for patients who could not be treated so far. Thank you for listening and welcome for questions.
To the panelists, there was one question I saw. This would be maybe addressed to.
Is typically
maybe we stop the questions, which I recorded.
In Germany,
we have a discussion for the last 10 minutes, maybe better.
Or chlorhexidine-based.
Or we see the cases.
I'll tell you what, there was a question regarding Inspire about a 2-incision approach for the sensing lead. Have any experience with that?
I didn't do it so far. I've done it on a cadaver, but I don't like it at the moment because the risk, if you go via or through the pectoralis major muscle, you have a higher risk of movement, and that means that you have a higher risk of torque on the leads. And as I showed on the video, there was this photo with the insulation damage, and I think the more you bend the leads, the higher the risk is that you have mechanical problems on the leads. So at the moment, I don't like it so much. I've never done it, but I know that some people try.
Any comment from the panelists beyond the usual contraindications for the surgery or selection criteria? Do you pay any particular attention to patients with anxiety and insomnia in particular?
Shall I start, Julia?
Sure, go ahead.
The most difficult patients are those in clinical routine who complain of insomnia, and that's the major reason why they cannot use their positive airway pressure. We have one patient with an IXOA device and a few patients with Inspire where we didn't take that as an exclusion, and they can be stimulated sufficiently during DICE, but they do not tolerate the stimulation because they have a superficial sleep, and they with minimal stimulation they don't fall asleep. So this is really a problem, and we have to focus more on this issue.
That's the same experience we've had through the trial patients we have at the moment, and it's meant to be an exclusion criteria if they have significant insomnia or psychological changes. But despite that, even with the best screening, there's still been several people through who just haven't been able to tolerate the device, and that's or the stimulator, the amount of stimulation that's going to give them any reproducible response, and so they've essentially failed.
It's great news that the Nyxoah folks have obtained approval for MRI scan. That's one of the big problems with the Inspire device. Even with conditional approval, it's hard to talk to younger patients in particular, about committing to that. Have you folks heard of any movement towards conditional approval with the Inspire for full body MRI scan? And how do you counsel your patients about that?
For Inspire, for full body MRI approval, in Europe, no. I don't know whether in the US, and it's, when we ask Inspire, they always tell us no, impossible at the moment. But
Right.
we know that radiologists have done, upon our request, in single cases. I know of 2 patients of ours where they performed an MRI of the lower abdomen for back pain, so lumbar problems with the spine, and where they did an MRI, even though it is prohibited, and there was no problem. But I don't know of any MRI in the neck and thorax region. I don't know whether you know of any or.
No. I've had to take one out because somebody needed an MRI scan and they weren't having a great result with the implant. So
we also will have to take one out during the coming weeks due to shoulder problems, which require an MRI, and there is not a really good efficacy, also due to insomnia. And so he requested after 1 year to have it taken out.
maybe if we have time, maybe both of you could comment on your experience with taking out an Inspire or a Nyxoah device.
I haven't had to do that yet.
We had to take out the previous generation of the Nyxoah devices, which were smaller than the new ones and not that stiff, more flexible, and which were never going to the post-market to the approval. So they were always pre-market, and that was easy to be done. You just cut open the pocket, the fibrous capsule, and then you cut a little bit around the legs of both sides, and you just pull it out. Now, and you cut the sutures. And I think it will be the same for the now used device. It's just a little bit more complicated to cut the sutures because they are deeper. With Inspire, taking out is not the big problem. You can just slide it off the nerve. You just have to follow the lead. And we did an exchange of a battery on Wednesday. And that was a patient who was implanted in 2010, so 11 years of use, and the battery was expiring 2 months ago. And taking out the battery, exchanging the battery was no problem. But after then exchanging the battery, we realized that there was a problem with the stim lead. And the stim lead didn't function well, so we had to exchange also the stim, not the stim lead, the sensing lead, sorry. And that could be done easily as well. For the stim lead, exchanging is a bit more complicated because you have already your fibrotic capsule, and you want to have the same spot if it was well working. And we did that in 2 cases, and they work well, but it's a bit tricky because you have scarring like an facial nerve where you have a paroidectomy and you go a second time, it's more difficult.
I had an experience one time having to replace the stimulating lead, and I went to the other side and just brought the brought the wire underneath the chin and back onto the same side. So it was kind of a contralateral implant. I was worried about the capsule and the fibrous tissue around that side, but it sounds like it can be done.
Maybe because I see questions regarding the cardiac implantable devices. We have done that, but not with defibrillators, only with pacemakers, and there was no problem. And it's no difficulty. And the bilateral stimulation in the Nyxoah, maybe a question also to Julia and to both of us. It's not always that after a while both nerves react with the same strength, because you may have small differences in impedance. So you do not always have a complete bilateral movement. And also with Inspire, we know that sometimes, even though there's only one-sided stimulation, we may have bilateral movement. Julia, what is your experience with the bilateral movement?
Very similar to that. There's even though it's supposed to be bilateral stimulation, you've got the implantable device sitting over both nerves, you tend to get a difference in stimulation between the sides. And you can see that usually even in the post-op, immediate post-op, when you're doing the external stimulation.
And that's sometimes making it a little bit difficult for the surgeon, because you have to wonder, shall I go on searching an even better spot?
Yeah.
Or go back because one side is reacting better than the other one. It's also amplitude dependent. So that, for instance, with lower amplitudes, you have only one side good, nicely reacting. With higher amplitude, both sides. Post-op care. Yeah, most often it's symmetrical, but you have that with Nyxoah, that it's not completely symmetrical. Post-op care. Yeah, Julia replied already, very similar. Yeah, but the activities of your shoulders is completely free with Nyxoah, but not with Inspire during the first weeks.
Paul?
Yes.
I'm going to wrap up your panel. Thank you very much.
Thank you,
Julia,
everybody.
you're still awake. It is almost 2:10 a.m. for you. Congratulations. I hope you don't have a lot to do this morning. I know it's a Monday morning for you. Joachim, thank you again for your participation and your expertise in nerve stimulation. We're going to bring our other course directors into view now as we wrap up. We want to thank the attendees. I want to thank all the faculty for the excellent participation. Remember, next year we're going to have this in person, and we'll be in Orlando in February of 2022. If you are interested, registration is open and you can join us very quickly. I want to thank our sponsors. I want to thank our gold sponsor, Airlift by Sleep Source Alliance ENT. Our silver sponsors, Inspire, Stryker, Philips, Olympus, Nyxoah, and the Florida Society of Otolaryngology Head and Neck Surgery. Without this sponsorship, this virtual program would not be would not be possible. Claudio, Julia, Filippo, thank you very much for co-directing this course with me. Your friendship is fantastic. This was our 8th year doing this together. It only gets better every year. And I want to thank the Nicholson Center staff. It's pretty educational to sit here in this room as they're jumping back and forth between presentations and all the computers they have hooked up. There's a lot that goes on behind this camera. So thank you very much, Nicholson Center staff. I'll let Filippo, Julia, and Claudio, if you have any comments you'd like to make.
Thank you to everyone who attended.
You're muted,
Oh.
Claudio. Claudio,
Yes.
you're on mute.
Okay,
There you go.
It's okay now?
Yes, we can hear you now.
Just a very quick comment. As you know, I'm Italian, so I do believe in miracles. You know, it was a miracle. We were part of at least 3 miracles in the last 2 days. Miracle number 1, faculty did an incredible job in spite to the virus, in spite to the pandemic, in spite to the very tight formula of webinar. Webinar was great, but webinar is a difficult formula for attendees. The second miracle was more than 200 attendees stuck to the screen for 8 hours in 2 days during the weekend. And Italy is very sunny, so it's even more important. The last miracle, your team, your Nicholson team, they were great. I know them since 8 years, so congratulations once more. Next year, we need to stay together, to dissect together, to discuss together, to attend to the fireworks together. That's the taste of the course. Today is just a break, but it was a very useful break.
Yes. Julia?
Just to say thank you to everyone who's attended. It's been great to have a whole lot of people participate. And I think one of the benefits of the webinar has been the chat function, where people can get feedback immediately from panelists and from attendees.
Yes. Filippo?
As every year, faculty can learn from questions and answers. We are lucky because every year can improve our knowledge thanks to the faculty and thanks to the attendees. See you next year.
See you next year. I miss everyone. It's been a year since we've been together. The last meeting that I've attended was this meeting last year in February, and that's the last time we were able to see each other. So I look forward to seeing you soon. Everyone stay healthy, safe, and we'll say goodbye. Thank you.